Hi guys, welcome back. Hope you're doing great, and let's get started for session number two for today. So the first session went a little unexpectedly a little longer, and what I'll do is to save your time, I'll try to go a little faster in this one. And I just wanted to inform you that the mock test would be going live very soon in the same fashion as it is in the actual exam. And we'll be having image-based questions, clinical scenarios, and most importantly, performance analysis. Checking out the performance analysis, let me know my weak subjects, and my objective would be that before the actual exam, the NEET PG or the FMG one, I would like to know like what are my weaknesses so that I can improvise on them, because we tend to make the strong subjects more stronger. But at the same time, I agree to the fact that strong subjects should be made stronger, but then the weaker subjects should also be made average, so that the curve becomes more flat rather than having those sinusoidal pattern. That's my opinion and my bits about it. So give me a quick thumbs up with respect to the audiovisual part, and we can get started for today. Yep. Very good evening, guys. Our objective would be to focus upon the endocrinology perspective. And some guys had put up this question before me, like, when to stop prophylaxis for a particular infection. I mean, the CD4 count should be more than how much that we are going to stop the prophylaxis. Though it's overlapping from pharmacology, I just wanted to remember for zero base, if the count is less than 200, we anyway have to start the treatment prophylaxis, that is cotrimoxazole. For toxoplasma, again, the same drug is used for prophylaxis, that is going to be cotrimoxazole. But then when should you stop this medicine is when the counts are more than 200 at a duration more than 3 months. For Cryptococcus, the cutoff is 100, with HIV RNA value being less than 500 copies per ml, and then 150 is the answer for histoplasmosis. So just get this number right: 200, 200, 100 and 150 for stopping the prophylaxis. And GT score does not, no, doctor, like, you should not worry about how many marks have you got. My suggestion to you is check out how many you got wrong. And out of those that you got wrong, let me say maybe 60% of those that went wrong, maybe you did not know, but 40% still were knowing and went wrong, right? Those are the things that need to be improvised on, because ultimately everybody is in the same boat. So most people will be making the same kind of mistakes. Difficult questions will obviously cause a problem. But then I think that it is like knowing that जो आता वो गलत हो जाता ना. That's if I put it in Hindi, like I know a topic and then I mess upon it. Like at zero base, I know that it's CD4 200, less than 200 is indication for starting treatment, and like if it's more than 200, I need to stop it. So like, those are like value based questions that sometimes can go wrong. So practicing them on a daily basis will make sense here. Okay, fine. Let's Okay, great. Let's go forwards and discuss the first question for today. Which of the following is not a feature of triad of autoimmune polyendocrine syndrome type 1? So nowadays, like, you will notice that he has stopped asking multiple endocrine neoplasia, because that people have started remembering men 1, men 2, men 3, and men 4. Instead, it is autoimmune polyendocrine syndrome type 1 and type 2 that is being asked in the comparison. And he says, which of the following is not a feature of the triad? Guys, please understand that when you talk about the triad of this particular condition, you have three things present: mucocutaneous candidiasis. Then is like this has an infantile presentation. There is presence of hypoparathyroidism in this condition also, and then there is Addison disease. The mnemonic for this is CHAI. So we get CHAI, that is mucocutaneous candidiasis is one. H is hypoparathyroidism, A is Addison disease, but we not a part of the triad is diabetes mellitus. Diabetes mellitus is given in Harrison for both type 1 and type 2, but it is not a part of the triad. That is the point that I want to say, whereas it is a part of the presentation of autoimmune polyendocrine syndrome type 2. The mnemonic to be remembered is C, because this is the first manifestation, that is mucocutaneous candidiasis. But then after cutaneous candidiasis, what you need to remember for autoimmune polyendocrine syndrome type 1 would be hypoparathyroidism, then is Addison disease, presentation in eye. The word eye tells you that it is presenting in infancy, and an additional manifestation that can be seen in these patients can be like hypogonadism, thyroid issue, and type 1 diabetes mellitus, but they don't form a part of the triad. So just this point has to be remembered, CHAI, and the I is for remembering the infancy component. whereas autoimmune polyendocrine syndrome type 2 will be having a presentation of Addison with type 1 diabetes. Addison is common between the two. Graves' disease can occur, and hypogonadism again is a common manifestation. So the correct answer for this one, since he's talking about the triad component, is option number C. I think in the last time's paper, it was multiple correct options. So these are three components that are present. And like if you have to select which are the three components, then it would be A, B, and D. If he says what is not a presentation of the triad, then the answer would be given as option number C. From the Chai mnemonic, things will become a little easier for you guys. Let's do another one, because calcium metabolism is again the lot of top aspects are asked from it. So he said you were drawing a sample for serum calcium. Whenever you were drawing a sample for calcium and potassium, one, you should not be using a thin bore needle, because if the RBCs will burst, it will change the values of potassium and can affect the change in the values of potassium as well. So don't try to use a thin bore needle, try to use the widest bore needle that is possible. Now, as far as calcium is concerned, calcium can bind to citrate, so that will cause a problem. And if a person will do exercise, like, lots of time to form a vein, you make the patient do like this activity. So when you make the patient do flexion and extension of the arm, it will cause lactic acid being produced, and this lactic acidosis component will cause a change in the pH of the patient. And when the pH changes, then the value of ionized calcium also tends to change. Like metabolic alkalosis contributes to tetany. Whereas if it is going to be acidosis, then it will cause an increase in calcium values. So there can be a falsely elevated calcium values that can be coming. The learning for you guys is that we can be having pH and calcium have an inverse relation. pH and calcium have an inverse relation. Like in metabolic alkalosis, we get tetany. In metabolic acidosis, we get is a falsely elevated value of calcium. So we should not be doing is a forearm exercise and fist clenching that we ask the patient to do. And immobilization of a person for long duration anyway causes a factitious hypercalcemia. So the question was like, which of the following is to be avoided in this particular case? So option number A, B, and C are the ones which are to be avoided, and therefore the correct answer for this question would be option number 2. The logic I'll explain once again. Calcium binds to citrate, so A is included. pH and calcium have an inverse relation, so flexing will contribute to problems and change in the pH. And prolonged immobilization causes hypercalcemia, that again causes factitious values to come. So answer to this is option number 2. And as far as potassium is concerned, what I was trying to explain was that especially for potassium, a thin bore needle, when the RBCs will travel through the thin bore needle, they will burst. This can result in development of pseudo hyperkalemia. This was itself a question. I mean, pseudo hyperkalemia seen where the answer would be use of a thin bore needle. Other causes for pseudo hyperkalemia can be like blood cancer, because in blood cancer the total cell count will be more. Any cancer per se, leukemias, lymphomas, solid organ tumors, because the total cell count is more, and when these cells will die, it will contribute to again a pseudo hyperkalemia occurring in a patient. So that is the that's the message at the moment with respect to calcium sampling as well as potassium sampling. And you guys can comment in the chat box with respect to what is the question for you guys is, what is the leading cause of hypercalcemia in a hospitalized patient? This was again a one-liner question which has been asked. Overall, most common cause of hypercalcemia in a hospitalized patient. Options are between parathyroid adenoma, where you get that stones, bones, groans, and moans, and lung cancer. Yes, malignancy. The leading cause of hypercalcemia. The leading cause for hypercalcemia should be answered as malignancy. And the malignancy that we are talking about is mainly lung cancer, or it can be breast cancer. And lung cancer and breast cancer can cause production of PTHRP, that is parathormone related peptide. So it is not PTH, but it looks like PTH, and that will drive up the calcium values. If I say asymptomatic patient, then it is parathyroid adenoma. But if it is going to be hospitalized patient, then the answer should be given as lung cancer / breast cancer. Also, you guys can comment in, no, it is not small cell cancer, man. It is not small cell cancer. I would like to clarify this. I good that I did not move this part, because this is again a common error. It is not small cell cancer. Small cell cancer banata hai ACTH. It forms antidiuretic hormone, that is ADH. Oat cell cancer / small cell cancer causes two paraneoplastic manifestations, the more common being syndrome of inappropriate ADH production, then is Cushing syndrome, and then is carcinoid syndrome. So these are like three paraneoplastic manifestations that are seen with oat cell cancer, but for hypercalcemia, it is squamous cell carcinoma. Parathyroid adenoma imaging has again been asked in the exam. Your answer would be given as technetium 99 SPECT CT. Technetium 99 SPECT CT scan is used for identification of parathyroid adenoma, which is a cause for hypercalcemia. Initially, patients are asymptomatic, and in the later part of the discussion, what they will do is they will subsequently tend to develop those stones, bones and groans manifestation. One more presentation is hypercalcemia drug of choice. Waiting for your answers quickly. I would like everybody to hit the comment box. What is the drug of choice for symptomatic hypercalcemia? Because if I will not intervene, it can cause a cardiac arrest. The type of cardiac arrest that would be written would be systolic arrest in a patient. Yes, drug of choice for symptomatic hypercalcemia. I am waiting for answers. Yes. That's a very common mistake that we made. Magnesium sulfate. No, guys, it's not magnesium sulfate. It is bisphosphonates that would be used for management of this condition. So we will be using intravenous bisphosphonates, like we can be using ibandronate, or we can be using zoledronate for this patient. And how ibandronate or zoledronate will work is it will be sending calcium into the bone. Since we had a bit of errors of judgment here, so I'll just clarify this information. So let's invest one quick slide about 1 minute into remembering the treatment of life-threatening hypercalcemia, because moment the calcium values start going in excess of 13, it's always a cause of concern because it can cause a systolic or a cardiac arrest in an individual. If he says what is the first line management, it is IV fluid. This will cause dilution, and the dilution part will then cause the calcium values to become like 12.8, 12.7. So at least the cardiac arrest component can be reduced. Now what I will do is, to the bottle of IV fluid, I will be adding furosemide. What this furosemide causes is calciuria. You know from your pharmacology classes that furosemide causes calcium loss in the urine, and that will bring down the calcium values to controllable levels. So first we have to stabilize the myocardium by using IV fluids and furosemide. Once it is controlled, then the next thing that we'll be doing in this patient is bisphosphonates. Why bisphosphonates are the drug of choice for this condition is because the action of these drugs will last for a couple of days. So over the next couple of days, you will be able to prevent and stabilize the myocardium of this patient. So bisphosphonates is the drug of choice. A drug that will act very fast but has a problem of tachyphylaxis, like calcitonin is given as a subcutaneous, can be given subcutaneously or can be given even as a nasal spray. The onset of action of calcitonin is very fast. So why it is not being called as drug of choice is because of the fact that it can contribute to development of tachyphylaxis, and that is why like the tolerance effect will come, whereas bisphosphonates effect will occur for a relatively longer duration. Yes, loops lose calcium. And subsequently, the next drug that we'll be using in this patient is denosumab. This is also a monoclonal antibody which is used in management of osteoporosis. Then we can be using, to bind to calcium, we can also be giving phosphate to the patient. This phosphate and calcium can then be binding to each other and can control this hypercalcemia. The last resort that I have at my disposal to manage this patient is going to be hemodialysis. So these are like steps for management of a rank ligand. And then hemodialysis is the last resort that I can be using for management of life-threatening hypercalcemia in the patient. So one, the basic concept is hypercalcemia is to be answered as what I have mentioned, and it is reverse if it is magnesium toxicity. If it is magnesium toxicity, it is there that we shall be giving calcium gluconate to the patient. Magnesium toxicity means the magnesium values are usually going in excess of more than 10 milliequivalents. That will again contribute to cardiac arrest in an individual. Though magnesium toxicity can be seen with Pritchard regimen that is used for management of eclampsia, but can be seen even in patients of chronic kidney disease. So that is where calcium gluconate will be useful for management of these patients. Magnesium sulfate, where it is to be answered, is mainly for hypomagnesemia. If the person is having eclampsia, that is where we use magnesium sulfate. We use it for management of torsades de pointes, that is polymorphic ventricular tachycardia. Patients of malnutrition, their magnesium sulfate can be given parenterally because there's a deficiency present. Then the next indication would be severe acute asthma. Yes, guys, even in severe acute asthma, it will relax the airways. Magnesium sulfate would be used. Yes. So Yes, severe asthma. Severe acute asthma is another situation where it would be used primarily. So those are like, situations where magnesium sulfate can be used, including that of hypomagnesemia. These are like indications for the various drugs that one should be remembering. In fact, calcium gluconate becomes answered for multiple situations. One is hyperkalemia anyway, where it stabilizes the myocardium. Then is like calcium gluconate for magnesium toxicity and tetany as well. Calcium gluconate, yes, magnesium can contribute to asystole, doctor. Yes. Calcium gluconate would be useful for following situations, that is in tetany, in hyperkalemia, where it will antagonize the relaxant effects of potassium on the heart, and would be useful for magnesium excess also, that is magnesium toxicity. Yes, we'll talk about magnesium in Gentleman syndrome also. I mean, it's not actually magnesium excess there, it's a hypomagnesemia that is seen with Gentleman syndrome. So great, guys. I think I had good answers there, and you guys can comment about the next one. You can see that purple vial here that is used for HbA1c. So I'm giving you options: continuous glucose monitoring, HbA1c. Then option can be fructosamine, and another option can be glycated albumin. Among the four options, you have to select as one that is best for monitoring of diabetes mellitus. Continuous glucose monitoring, glycosylated hemoglobin, where that lavender vial would be used. That lavender vacutainer would be used, again a favorite with our examiner. Then is fructosamine and glycated albumin. There are four options that I put up, and the question said like which of them is best for monitoring of diabetes. See, earlier the answer for this was HbA1c, but HbA1c, the disadvantage is it does not talk about hypoglycemia. Diabetic patients, they suffer from both hyper as well as hypoglycemia. Sometimes you will notice them very lethargic, very tired, they'll be sweating all over. That's because the blood sugar will crash. And continuous glucose monitoring at the moment, guys, the answer to this question is not HbA1c. The answer for best help for monitoring of diabetes mellitus in the updated guidelines is CGM, that is continuous glucose monitoring. Okay, role of corticosteroids in hypercalcemia. Doctor, give me a second. In the inferior part of the slide, I'll just answer that, but that's a good question you put up, Prem, so I'll answer this at the bottom of the slide. Best test for monitoring of diabetes mellitus is continuous glucose monitoring, not HbA1c, because CGM will give a visual reinforcement, because you can sync it with the mobile phone of a patient or with a glucometer, and the patient will have a real-time evidence of like his sugar is rising or falling. If it is rising, at least he'll try to avoid chole bhature, he will try to avoid snacks, or like he will avoid ordering from Swiggy and Zomato, and he'll try to eat home cooked food, because restaurant food is gonna be like mostly carbohydrates and trans fats, so his sugar will spike much more faster as compared to eating home cooked food. And then you'll keep on continuing to experiment, and finally will find a right combination where the sugar of this patient does not spike and does not fall very significantly. As far as glycated albumin or fructosamine are concerned, they both mean the same. Both of these tests are useful for short-term control of diabetes mellitus. Both of these molecules, they are useful for short-term control of diabetes mellitus and not for long-term control. Long-term control is HbA1c, but best for long-term control of monitoring of diabetes now is CGM, because it helps in diagnosis also. And next I'll mention regarding a question that came up, like when would you be using steroids in a case of hypercalcemia? So those are the situations when steroids would be useful. One of the best indications for using steroids or steroid responsive hypercalcemia is sarcoidosis. I think somebody commented about that in the chat also. Yes, very good answer. Then the second indication for giving steroids would be multiple myeloma. This is again where you would be having those lytic lesions in the skull, and the treatment that we give in multiple myeloma is lenalidomide and dexamethasone. And the third indication where we give steroids for management of this patient is going to be vitamin D intoxication. So these are like three situations where you will be answering in the MCQ: steroid responsive hypercalcemia. The statement of mine is steroid responsive hypercalcemia. Now coming back to the agenda, I'll say this once again. Latest answer for best test for monitoring of diabetes mellitus is continuous glucose monitoring. As far as fasting values are concerned, that you anyway know should be less than 100. All the values are in milligram per deciliter. We will then be making the patient drink 75 gram glucose, and after 75 gram glucose, we will be then checking the blood sugar values after 2 hours. Those of you who want to comment here quickly can comment regarding like what is that value that you calculate or use after 2 hours called as. A very silly question, but anyway, like what is that value called as? HbA1c is not accurate. One of the main reasons for falsely low HbA1c in Indian population is iron deficiency anemia. The number one cause of falsely low HbA1c is iron deficiency anemia. So a lot of Indians are anemic and therefore their HbA1c can be normal also in spite of the fact that they're diabetic. No, we don't call it postprandial, boys. That is what I'm trying to tell you. It is called as a 2-hour value. Please listen to the words very carefully. The question may look very silly, but it is not postprandial. This was actually a question that has been asked so many times, that what test is not useful for diagnosis of diabetes? The answer is postprandial value. The postprandial glucose values, or the postprandial plasma glucose values, they are basically, the postprandial plasma glucose values are useful for monitoring of diabetes, or rather better than monitoring, I can say the word follow. If I want to check my patient is regular with his medicines or not, then after taking medicines, the value of control sugar should become relatively normal. So it is not postprandial plasma glucose, it is 2-hour value that is used. Yeah, the test we are doing is oral glucose tolerance test, but the question was like, what is the value taken after 2 hours called as? It is simple 2-hour value, and the value should be less than 140. Then he said that you are making a guy unfit for recruitment into police. Maybe the recruitment drive is going on for recruitment into Delhi police, and you have made a guy unfit because his fasting values were in the medical. You have made him unfit for recruitment because his fasting values were between 100 to 125. And he said like, what is the technical word that you'll use for it? So your answer would be given as impaired fasting glucose. But if the value of this patient, like he's saying, no, I want to appeal. So you'll say, yeah, we can make you drink make 75 gram glucose and check your 2-hour value again. And if it comes between 140 to 199, then we will call it impaired glucose tolerance. So there are two more terms where I added impaired fasting glucose, and then is impaired glucose tolerance test. And the extreme right hand side is obviously a straightforward diagnosis, that is 126 and 200 milligram. And it is like, if somebody comes with at least only one report, like only fasting report, so single fasting report will not be sufficient. We would need more than one report at least. Ideally it should be like 120 and 200 with the proper test being done. Otherwise, like at least two fasting reports should be turning out to be more than 126 for diagnosis of diabetes mellitus. And the category that I mentioned in the middle here would be pre-diabetes. The category that I mentioned in the middle in this case is called as pre-diabetes in English, but the technical words are impaired fasting glucose and impaired glucose tolerance. Leading cause of falsely low HbA1c in Indian population would be answered as iron deficiency anemia. That is the reason why a lot of Indians, they might be having because they are having anyway iron deficiency anemia, and they're having diabetes also, so their HbA1c tends to be on the normal side or lower side, or lower. It may be like less than 7%. Like the cutoff for diabetes is obviously 6.5, but the values might come to be more than 6.5 but less than 7, giving you an impression as if diabetes is controlled, but it is because of the anemia component. Then usually there is always a question with respect to a sick, unconscious, unresponsive diabetic patient. I'll give you a situation. The pH of the blood is 7.2, so there is acidosis. The bicarbonate of the patient is like 15 milliequivalents. There is urinary ketones which are 4 plus in this individual. The random blood sugar of this patient is turning out to be 300. One, I think everybody is aware of the triad. The triad would be a total of 3 things. The triad does not include pH. The triad includes bicarbonate value. Triad does not include pH. Triad includes bicarbonate, urine ketones, and random blood sugar to be more than 250. These 3 things that I mentioned before you is triad, and that is when you can say this is diabetic ketoacidosis. But in some questions, he can play a trick and he can give you a value like this where there is a acidosis but the ketones are absent. Even in the blood, the beta hydroxybutyrate values are normal. The blood sugar value of the patient is given to be 300. In those circumstances where the ketones are given to be absent, then you cannot answer it as diabetic ketoacidosis. In the first report, obviously it is diabetic ketoacidosis, but in the second report, it will not be diabetic ketoacidosis. As you can see in the figure, the value of ketones is turning out to be negative. So in these circumstances, you will now check for serum lactate levels, which are turning out to be elevated. And if this is the situation, then you will change your answer to lactic acidosis. A lot of diabetic patients who may be on metformin, because metformin is contraindicated if the person's estimated GFR rate is less than 30. But if a doctor has not checked the GFR of the patient and metformin has been given, then person can land up in lactic acidosis also. So it is LA lactic acidosis, though the first entry I mentioned is diabetic ketoacidosis. Then the next possibility in the question can be, I'll use a different color for this, like the pH is given to be normal, bicarbonate is given to be normal, ketones in the patient are given to be absent or may even be given to be like 1 plus 2 plus because of starvation component. If the patient is sick and is not eaten, if the patient has not eaten, I want to clarify here guys, don't be surprised if ketones are given in this question. Ketones can be given in this question usually like 1 plus or 2 plus because of the starvation, because if patient is sick then he can't eat anything, he cannot eat anything. But the pH is normal and the bicarbonate value is also normal and the blood sugar is gonna be like usually in excess of more than 600, then we will be saying it as hyperglycemic coma. Hyperglycemic hyperosmolar coma. I'm writing HH for it. That is hyperglycemic. The sugar of the patient is super elevated, right? So there is a hyperosmolarity that is occurring that will contribute to fluid shift across the brain and the patient will become unconscious because of this. So hyperglycemic coma, I can write, okay, let me just write the word hyperglycemic coma only. That would be hyperosmolar coma. Hyperglycemic hyperosmolar coma is the presentation for the third entry. The main aspect I want to highlight is that ketosis can be present in hyperosmolar coma primarily because the patient is sick, so is not eaten for 1 day or 2 days, so there would be endogenous fat degeneration and the fat will break down to produce ketones. The next possibility in the question can be, and I'll put it in red, like he can say the pH of the patient is 7.38, bicarbonate is 24, urinary ketones can be given to be 1 plus or 2 plus because any sick patient ketones can be present due to starvation also. The blood sugar of this, it's a known diabetic, blood sugar is turning out to be 150. In a known case of diabetes mellitus, 150 is not a cause of error and even the serum lactate values are normal. So you guys comment here like what could be the possibility that this guy has become unconscious. I'm dealing with the unconscious unresponsive diabetic. He's sick for 1 day, he's not waking up since let me say yesterday evening. So now in the evening, the family members have brought him from rural India, from a village. They went to some local hospital, some private nursing home yesterday night. Then they shifted them to district hospital and now they come to your tertiary care hospital. Yes, you will think in terms of cerebrovascular accident and you will be doing a non-contrast CT scan in a patient, because if it is not a metabolic cause, then it can be a neurological cause for unconsciousness in a patient. So most of the time in the paper, you will notice that any of the 4 permutation combinations can be asked to you. As far as diabetic ketoacidosis is concerned, I have already explained to you, but I'll just do it once again. The first step in management of this patient is normal saline. Normal saline should be given to this patient because it will be correcting the dehydration, because there would be contracted vomiting present. And to the bottle of normal saline, we will add potassium chloride also. To the bottom of normal saline, we will be adding potassium chloride. This potassium chloride is mainly to compensate for the GI losses, because the guy would be having a lot of vomiting, so GI losses are to be taken care of. And the second reason why we giving potassium chloride is because insulin will be causing a potassium influx into the cells. So I know in advance only that I will be giving insulin to the patient for management and the potassium will be redistributed inside. So to counterbalance that, I will be giving potassium chloride to the patient to the tune of like maybe 40 milliequivalents per liter. That will be added to the bottle of IV fluid. And after 1 hour, in this case of diabetic ketoacidosis, we will be starting insulin drip. This insulin drip would be of the regular variety. This insulin drip that would be started in this patient would be of a regular variety, and this would be given in the form of an infusion. And now we don't give a bolus anyway. That has been discussed multiple times in our previous sessions also, that the bolus part has been discontinued. So after 1 hour, it is like we'll secure 2 IV cannulas. One IV cannula will be for normal saline with KCl added to the bottle, and second will be for specially regular insulin infusion that would be given to this patient. Prem, yeah, there is a slight difference in a sense that diabetic ketoacidosis is more common in children. So you will be following the adolescent diabetes foundation guidelines. So I would suggest you to follow this, as I have mentioned. This has been asked in NEET PG multiple times. So that is why it is important to follow this information. There's a subtle difference, Prem. You are right in that in Harrison for adults it is bolus also given, but we'll go by because usual age group is pediatric age group only. As far as diabetic ketoacidosis is concerned, the triad I would like to mention once again. The triad will be having a random blood sugar amount not 200. The triad here will be a value of more than 250. Just take care of that value. It is not 200. It is more than 250 milligram per deciliter. Plus you would be checking bicarbonate and not pH. The bicarbonate should be less than 15 milliequivalents and like DKA. So there should be evidence of ketonuria. Either there should be evidence of ketonemia. where I can be checking serum beta hydroxybutyrate values. Otherwise, instead of ketonemia, I can be checking for ketonuria in this patient also. So fluid to be followed by KCl. Yeah, fluid. No, it is not. Digvijay, I'll just modify what you said. It is not KCl to be given separately. It is NS to be KCl to be added to the bottle of IV fluid and to go concomitantly. You have to hold insulin. Here you have to, before you start insulin, no, the important statement is hold insulin if potassium in the blood is less than 3.3. This was an FMG exam question, very simple. कि भाई कब insulin नहीं देंगे तो भाई if the potassium is less than 3.3 then we will hold insulin in the patient. Let the potassium come back to normal. It will take another extra half 1 hour की जगह पे 1.5 hour लग जाएगा, 2 hour लग जाएगा, and then subsequently we'll be managing the patient effectively. Ringer lactate can also be used, but ringer lactate में ना potassium बहुत less होता है. The amount of potassium in ringer lactate is only 4 millicoulomb per liter. That is like too less a value, and that is why therefore it is not recommended, and what we can use is normal saline for management of this patient. Yes, Rajat, very well. It is. What is the biggest side effect of normal saline infusion? Yes, guys. What is the biggest side effect of normal saline excess? अगर हम ज़्यादा normal saline दे दें तो क्या नुकसान आएगा? Insulin sends potassium inside the cells, na? But will cause hypokalemia. If you give normal saline excess in an individual, normal saline is sodium chloride. So first there would be a development of hyperchloremia. Hyperchloremia means negative charges in the body. Negative charges in the body will increase. If the negative charges in the body will increase, so the body to counterbalance this will send bicarbonate into the cells. And if bicarbonate will go into the cells, it will contribute to development of acidosis. I asked a simple question to you guys. What is the side effect of too much of normal saline? Normal saline is sodium chloride. It is 0.9% NaCl. अगर आप किसी पेशेंट को सलाइन ज़्यादा दे दोगे तो क्योंकि सलाइन में क्लोराइड होता है तो बॉडी में नेगेटिव चार्जेस इंक्रीज हो जाएगा. आई एक्सप्लेन बोथ इन हिंदी एंड इंग्लिश, सो प्लीज डोंट इंटरप्ट. क्लोराइड का मात्रा बढ़ जाएगा बिकॉज क्लोराइड इज नेगेटिव चार्ज. Because negative charges will increase, the body will want to maintain electroneutrality. Human body is like balancing act. So if negative charges बढ़ जाएगा, so body will send bicarbonate inside the cells, and when bicarbonate will go inside the cells, it will cause metabolic acidosis. So the side effect of normal saline excess is hyperchloremic acidosis. The learning point is don't give too much of normal saline, otherwise your diabetic ketoacidosis patient can worsen also. This was a question of the paper again. What is the side effect of excess of normal saline? It is hyperchloremic acidosis. Now I'll explain the same thing in English, so please bear with me for 30 seconds. If you give normal saline, chloride values will increase significantly. Chloride is negative charges, negative charges. If negative charges will increase in the blood, the body will try to maintain electroneutrality. En basically stands for body is trying to maintain electroneutrality. So it will try to counterbalance by sending negative charges in the form of bicarbonate inside the cell. And if bicarbonate goes inside, then metabolic acidosis of the original acidosis of the patient will worsen in this particular case. So this is a big side effect that we see with normal saline excess. Somebody had answered that it will cause metabolic alkalosis. No, doctor, that is answered for ringer lactate. Ringer lactate contains lactate. This lactate is metabolized by the liver to produce bicarbonate. If somebody will give too much of ringer lactate to a patient, if I put plus here and you're giving too much of ringer lactate, then more lactate will be going in the body. If more lactate will go in the body, it will cause more generation of bicarbonate, and more generation of bicarbonate will then cause metabolic alkalosis. So the side effects of fluid is what I've explained to you, and they always ask about fluids whenever they're discussing any kind of an exam. Normal saline excess causes hyperchloremic acidosis, ringer lactate excess causes metabolic alkalosis to occur in this patient. Central pontine myelination, that is with respect to hyponatremia correction. If I am doing hyponatremia correction, that is when in hyponatremia correction, we will be having is a development of central pontine myelinosis. Like if there is a hyponatremia, dangerous hyponatremia is defined as value less than 125 millicoulombs per liter. That is when patient can end up with development of seizures. So if a patient is having acute onset hyponatremia, like best example of that is marathon running. In acute onset hyponatremia, what we will give to the patient is fast correction. We will be giving fast that is bolus of 3% saline, and this fast 3% saline will cause correction of hyponatremia. But if a patient is having a chronic onset hyponatremia, the best example for chronic onset hyponatremia is SIADH in an individual. SIADH will cause more water, water will cause dilution and will cause hyponatremia. In chronic onset hyponatremia in a person, it is recommended for a slow correction. Here the slow correction means that you should be causing something like a 8 milliequivalent rise per day. If, however, a doctor will cause a correction straight away from 125 to 145 in one day only, then the problem will occur. So for chronic onset hyponatremia, if a fast correction is done with 3% saline, that is the trouble. That is the bad news. And that can contribute to development of osmotic demyelination syndrome. That osmotic demyelination syndrome is what is called as central pontine myelinosis. So I originally did not plan to discuss this, but since it came up, so I thought I should be mentioning regarding this, that if it is going to be fast correction done, then it will cause deterioration of this patient. That deterioration would be in the form of osmotic demyelination. Osmotic demyelination will cause stroke-like manifestations. So they would be like abulia, they can be like apraxia, quadriplegia, because corticospinal pathway will also be affected bilaterally. So arms will also be paralyzed, legs would also be paralyzed. So we should always go for a slow correction in chronic hyponatremia and a fast correction with respect to acute onset hyponatremia in an individual. Why? Okay, I'll address that query because we are discussing electrolytes only. So, an interesting question that came up is Himanshu said in Conn syndrome why there is an alkalosis. So, I'll explain this to you. I think it's very simple, but still I should address these queries. Like aldosterone is more na, so aldosterone will cause like more salt and more water to come in the system. So that will explain the hypertension component. और aldosterone जब काम करता है ना, तो it acts on the kidney via the epithelial sodium channel, so it will cause a exaggerated, as you can see in the figure, exaggerated urinary loss of potassium as well as hydrogen. तो potassium भी निकल जाएगा और साथ में potassium के साथ साथ में hydrogen भी निकलेगा. So Conn syndrome always causes is a hypertension with hypokalemic alkalosis. They love to, this is the thriving part, guys. I mean, electrolytes is something that I would like you to first listen from rapid revision, then come here and you would be like on the way to understand these aspects. And it's a very short discussion, but that would help you understand the disease processes relatively better. Okay. So what we have discussed at the moment is diabetic ketoacidosis. To see whether you've got me or not, I'll put up a question before you. Like this is a 8-year-old girl. She is admitted with a diagnosis of pneumonia. Pay attention to the question for next 1 minute and then we can go ahead. This is a patient of 8-year-old girl. She is admitted with a diagnosis of pneumonia for 2 days. She is on IV antibiotics. And since last night, she is having vomiting. She is also very drowsy. So today afternoon, you have noticed that because mother was saying that the child is very drowsy, there's a lot of vomiting, there was a lot of abdominal pain and the symptoms are persisting since last night. So you decided to do a basic workup of the patient and you found that this patient's VBG or ABG, venous blood gas report was done or arterial blood gas report was done. VBG and ABG are good enough for diabetic ketoacidosis because you don't need to check the oxygen values. So the pH of the patient was turning out to be, let me say 7.3, or let me just put it like this, that in this patient, the random blood sugar of the patient is turning out to be 350. Instead of talking about ketones or acidosis part, let me say random blood sugar of the patient is 350. So that's fairly substantially elevated. And there is a ketonuria, which is documented in this patient as well. The ketones have been documented. And he says like, what is the next step for management of this patient? The options before you are, one is to perform an ABG. Another is to start IV fluids in the form of normal saline. The next option before you is that you should be giving insulin to the patient in the form of a bolus. And the fourth option before you is that you should be giving insulin in the form of a drip for this person. So I can expect answers from you guys to see that you've got me or not. In this particular case, child is admitted with a diagnosis of pneumonia. Random blood sugar is turning out to be 350. Ketonuria is present, but you can see that there is no ABG report given in the question. They are just playing with words in these questions. Basically, the point is first you need to demonstrate the triad of diabetic ketoacidosis, and the triad of diabetic ketoacidosis will include serum bicarbonate. Without bicarbonate value being less, I cannot say that this is gonna be metabolic acidosis. So the answer in this patient will be contributing to determining the bicarbonate value. So this is like another version of a question that I wanted to bring to your attention, that don't straight away answer normal saline for the question. Check out whether the triad is being satisfied or not. Now I will be giving you the same presentation. It is the same question that I'm describing. Everything that is given is same. I'll write down the values once again. Random blood sugar of the patient is 350. There is a presence of ketonuria, and even the ABG report is given in which the bicarbonate value is given to be, let me say, 10 milliequivalent. So this time he has satisfied the triad. Same question with triad being satisfied, but is mentioning that the BP of the patient. Yes, a patient is drowsy now, so I will be managing first by doing ABG of the patient, and only then you can start treatment. We don't immediately start treatment. In evidence-based medicine, you first have to demonstrate that there is a illness, and then only then you can treat the patient. So that is why, that is what I meant by managing, that I'll not give IV fluids to the patient. And then in version 2 of the same MCQ, या वी हैव टू करेक्ट, बट एबीजी सैंपल लेने में कितना टाइम लगेगा? तो जितने टाइम में आप कैमरा लगा रहे हो, दूसरे बात उसे एक एबीजी का सैंपल ले लेंगे, इतना ही तो है. सो प्लीज अंडरस्टैंड, ट्रायड इज टू बी सेटिस्फाइड. बिना ट्रायड के हम इलाज नहीं कर सकते हैं. Then is, if I change this question and like the options I can give before you are, one is I can keep it same, like I will have to give in this particular case IV fluids to this patient in the form of a bolus. That is one option. Then is IV fluids to be given to this patient as regular infusion. Then is insulin, that is in the form of a bolus. And then is insulin in the form of an infusion. Among the 4 options that I've currently mentioned before you for the same question, where the BP of the patient is unrecordable, then in those circumstances, it is IV fluids that would be given bolus format first, so that you can make the BP recordable. I mean, he may mention sunken eyeballs, dry oral mucosa, minimal urine output, altered sensorium, seizures in a patient. If they give you those classical danger signs with respect to dehydration, then it is bolus IV fluid that should be given for this patient. So this would be the algorithm that would be used. BP will not be, if somebody is vomiting, then BP cannot be increased. No? I mean, why would a child have a hypertension? If it's an adult, then it is okay. If it's an adult patient with diabetic ketoacidosis, it's a hypertensive patient, then it is okay for this manifestation. डायरिया विद सिवियर डिहाइड्रेशन, हाइपोकैलेमिक, मेटाबॉलिक. डायरिया में मेटाबॉलिक एल्कोलोसिस नहीं होता ना मौलिक. डायबिटीज, जब भी किसी को डायरिया होता है तो डायरिया से हाइपोकैलेमिक मेटाबॉलिक एल्कोलोसिस नहीं होता है, डायरिया से मेटाबॉलिक एसिडोसिस होता है. तो रिंगर लैक्टेट देते हैं ना, मेटाबॉलिक एल्कोलोसिस तो हो ही नहीं सकता डायरिया के साथ में. तो इट इज RL टू बी मेंशन्ड. You did not mention the age of the patient. It doesn't matter. Diabetic ketoacidosis is more common in children ना. ठीक है, तो एडल्ट्स में तो टाइप 2 डायबिटीज होती है ना, तो उसमें तो रिलेटिव इंसुलिन डेफिशिएंसी है, वेयर एज द मेन कॉज ऑफ डायबिटिक कीटोएसिडोसिस इज इंसुलिनोपीनिया. इंसुलिनोपीनिया मींस टाइप 1 डायबिटीज, एंड दैट इज अ पीडियाट्रिक ऑन्सेट डायबिटीज. ओके, दैट्स अ गुड क्वेश्चन. व्हेन ABG is preferred as compared to VBG, whenever I have to check out the PO2 values of a patient, is if specially I want to check out the accurate PO2 and PCO2. So especially for like respiratory acidosis patients, respiratory alkalosis patients, lung diseases like COPD patients, that is where I'll be preferring ABG over a VBG. But in diabetic ketoacidosis, if a mother is not giving permission to do ABG because it will require you to poke an artery, and it's also painful, so if a mother does not give consent, it's okay. I mean, we can do a VBG in a patient as well. But for patients who are having COPD, or who are having severe acute asthma, who are having interstitial lung disease, patients who are on mechanical ventilation, that is where we will be using especially ABG report. ABG, because PO2 in venous sample is hardly 40 millimeters of mercury. PO2 in venous sample, PCO2 in venous sample is more than what is present in ABG sample, so it can overestimate respiratory acidosis. But the PO2 value will be dramatically less than 40, or approximately 40 millimeter. So that's why, like in lung conditions, we will be having evaluation. Why to check bicarbonate? Because actually it is consumption of bicarbonate. Now the ketones are acidic in nature, so they will cause consumption of ketones in a patient. See, pH can be affected by multiple reasons. So it is not the pH that should be checked, it is bicarbonate, because after all, why is the pH falling? Bicarbonate consumption. Na? Why? My question is, why is the pH becoming less than 7.35? Because there is a bicarbonate consumption, and because there's a bicarbonate consumption occurring, so I will be checking bicarbonate value, which is the direct evidence as compared to indirect evidence of pH. That is why in the triad, pH is not included. So I think I've addressed almost all the questions that I mentioned. Prem also came up with a very good input. Bolus shots followed by 10 milligram per kg infusion. Yeah, I mean, if they mention the values, cool. Otherwise, the bottom line is unrecordable BP. Unrecordable BP in a patient, we first have to go in for correction. So these two questions are gonna be like, literally playing with our emotions, because everybody is like raring to answer it as IV fluid infusion. And one option will always say IV fluid infusion followed by after 1 hour insulin drip. That is correct answer if the vitals of the patient are not crashing. If vitals are not crashing, cool. I mean, you answer IV fluids followed by 1 hour, you give an insulin infusion to a patient, you add KCl to the bottle IV fluid, cool. But if it's gonna be crashing patient, then bolus. And in those circumstances where it's gonna be random blood sugar being elevated, but acidosis is not given, then ABG of the patient needs to be done. Bolus is preferred in shock patient. Absolutely right, Natasha. Bolus shots would be given in any patient with circulatory failure. And what we'll do in this case is give normal saline only. These were aspects for diabetes. Okay, I'll invest one more slide for this before we go forwards. And you guys can comment here like which anti-diabetic drugs cause worsening of cardiovascular mortality. All the questions that I'll be mentioning on this particular slide are for diabetes mellitus. Yeah, same for adults, doctor. Same for adults. Unless until it is diarrhea. Diarrhea में ringer lactate देते हैं, otherwise तो normal saline देंगे ना. Okay, which anti-diabetic drugs would contribute to worsening of cardiovascular mortality? Then your answer would be given as worsening of cardiovascular mortality would be seen with molecules like pioglitazone and rosiglitazone. So that category that we're talking about is thiazolidons. The opposite MCQ of this can say which will lower cardiovascular mortality. Yes, quick comments in the chat box. Yep. Yes, electrolytes would not be changing. Electrolytes would not change much. No, it's not gliflozins, guys. It is not gliflozins. Your first answer is GLP-1 receptor agonist. That GLP-1 receptor agonist that we'll be using is semaglutide. This is the first answer in the question. If this is not given, then it is gliflozin. That is SGLT2 inhibitors would be used, like empagliflozin, canagliflozin would be used subsequently. But if it is reduction of cardiovascular mortality, then it is GLP-1 receptor agonist that would be answered initially. The next question says which is anti-diabetic drug which is used in both type 1 as well as type 2 diabetes, apart from insulin, obviously. Which anti-diabetic drug can be used in both type 1 as well as in type 2 diabetes mellitus? Yeah, a myelin analog, no? So your answer would be given as pramlintide. The next question will say which drugs are used to slow down the progression of diabetic nephropathy? Yes, guys, quickly mention regarding medicines that are used to slow down the progression of diabetic nephropathy. Yeah, pramlintide is one of them. Drugs to decrease the values of progression of diabetic nephropathy. First answer would be ACE inhibitors, because they will cause a efferent arteriolar dilation and they will reduce the damage to the basement membrane. The second molecule that you will be using would be SGLT2 inhibitor. Yes, very good, very good. ACE inhibitor is the first line, then is SGLT2 inhibitor. I mean, you can also say slow progression. Slow the progression of chronic kidney disease. Yeah, the third molecule is finrenol. But linagliptin will not contribute to any progression slowing. It is just a drug that is metabolized by the liver, so that is just pharmacology. But my question here was more specific. I said like which medicine will you be using or prescribing so that you can be reducing the progression of chronic kidney disease. So it is ACE inhibitor, it is SGLT2 inhibitor, and then instead of spironolactone is finrenol. But then as somebody commented also that linagliptin is not going to change the dynamics of the progression of chronic kidney disease primarily. CKD progression would not be prevented. Then for weight loss in diabetes also, the main drug that would be used is semaglutide. Tirzepatide and semaglutide are molecules which are useful for management of this patient. Any side effect of semaglutide you can tell me, or tirzepatide you can tell me? Weight loss is tirzepatide and semaglutide. Weight gain can be seen with sulfonylureas now, because sulfonylureas cause increase in the value of insulin. If you cause a burst of insulin to rise, insulin secretagogues, then that can cause a weight gain. Yeah, pancreatitis. Very good. One of the side effects of this can be hemorrhagic pancreatitis. That is a side effect which is to be remembered. Absolutely. Hemorrhagic pancreatitis is one of the big side effects that would be coming. Okay. Yes, yes, Dr. Basista Day, I answered that the electrolyte sodium potassium will not have too much of variation with respect to the arterial and the venous samples, because normally also na, you take a venous sample for potassium na, and for sodium also you take a venous sample. So arterial sample and venous sample will not have too much of differences with respect to sodium and potassium. Yes, a bit of differences can be there with respect to potassium, but that will not affect your therapeutic decision making. It is mainly the oxygen values that would be. मेटफॉर्मिन बच्चे इज वेट न्यूट्रल. मेटफॉर्मिन इज वेट न्यूट्रल ड्रग. उसके लिए तो मैंने बहुत रेफरेंसेस दिखाए हुए हैं. मेटफॉर्मिन इज अ वेट न्यूट्रल ड्रग, राइट? Yes, absolutely. Okay, so these are like questions on anti-diabetic drugs, which I thought that I should just be quickly mentioning before you. Okay, I think I've addressed majority of the queries for this one. Yes. Yes, yes, yes. Okay, one more question for you guys. What is the drug of choice for management of MODY3? Drug of choice for management of MODY3. साइकोसिस इंड्यूस ओबेसिटी में मेटफॉर्मिन डॉक पीसीओडी बोल रहे होगे ना, पीसीओडी में देते हैं, नॉट साइकोसिस, बट पीसीओडी में मेटफॉर्मिन दे रहे होते हैं. दैट इज ओके. बट या आई मीन अगर आप ये कह रहे हो कि फ्लुओक्सेटिन खाने से हो गया, पैरोक्सेटिन खाने से वेट गेन हो रहा है, तो देन इट इज लाइक मेनली एक्सरसाइज दैट वुड बी हेल्पफुल फॉर द पेशेंट. या ग्लिपिसाइड. मोडी 3 will be glipizide, not bigonides, no? Only type of diabetes where we start the treatment with sulfonylureas is MODY 3. बाकी सारों में majority onset diabetes of young is where we'll start the treatment like this. Now MODY 2 में तो no treatment is required at all. I mean it's a mild illness, but then MODY 3 is glipizide sulfonylureas that would be used for management of these patients. It's not metformin, guys. MODY 3 is the treatment is started with sulfonylureas. What is the most common complication of diabetes? Long-term complication of diabetes? You want me to give options? Retinopathy, neuropathy, nephropathy, coronary artery disease. What is the most common complication of diabetes mellitus? Majority onset diabetes of young is a disease in which the production of insulin is low, but beta cell mass is normal. Normally beta cell mass is gonna be reduced in type 1 diabetes, but in MODY it is beta cell mass is normal. So it is a problem with release of insulin from the beta cells, because the enzymes involved in the process of insulin production are defective. But the beta cell, I mean, difference between MODY and type 1 diabetes is both have insulinopenia, but beta cell mass is normal. So therefore the cells can be stimulated. I mean, that is the main core point here, that because the beta cell mass is normal in this case, that is why you can stimulate those cells to produce more of insulin, and that is why glipizide is used. Overall, the most common complication of diabetes mellitus is diabetic neuropathy. I asked very simple questions on this slide, guys, and they were very straightforward ones. The most common complication of diabetes is neuropathy. Suppose I asked you what is the cause of death, then the cause of death will be answered agreed. The cause of death would be answered as coronary artery disease. But overall, the most common complication that would be answered is gonna be answered as no, Prem. It is not a new type of diabetes. That was always there. Fibrocalcific diabetes was seen in Africa and India, rural India में, छत्तीसगढ़ में आज से 20 साल पहले भी हम पढ़ते थे कि जो छत्तीसगढ़ में जैसे कई स्टेट्स ऐसे हैं इंडिया में, वहां पे जहाँ पे फैमिन ज्यादा होता है, सूखा रेट पड़ता है, जहाँ पे गर्मी बहुत ज्यादा होती है, जमीन फट जाता है. So even like 20 years ago, we used to read about diabetes occurring in children in rural India because their pancreas was damaged by starvation. So it's not a new thing that only FDA has mentioned, like they've acknowledged it in the books now, but we used to call it fibrocalcific degeneration of the pancreas, and that used to occur even 20 years ago. I mean, 20 years ago, I presented a paper in my one of my ward presentations regarding the prevalence of malnutrition, diabetes in malnourished population of India. That is what I presented upon. So it is like it's not a new thing. It's just on social media suddenly something blows up, and they given a name for that is type 5 diabetes, but it's not a new thing, guys. Okay. Yeah, neuropathy is the most common complication. Okay, so quick comments here. What is the investigation of choice for diagnosis of Cushing syndrome, where there is a hypercortisolism? The cortisol values in our body will keep on fluctuating. the least values of cortisol, are seen at 12 a.m. in the night. The values of cortisol in human body will keep on fluctuating. This is for a normal individual. The least values are gonna be relatively lesser. Guys, if they say what is the investigational choice for diabetes mellitus, investigational choice for Cushing syndrome, and in the options they have also mentioned regarding this particular test, where you will wake up the patient at the middle of the night and you can check his salivary cortisol. Ideally, the best way for diagnosis of this condition is what is called as midnight salivary cortisol. My suggestion to you guys who are listening is do check out the rapid revision in the Hindi version. That will help you understand this process relatively better. Midnight salivary cortisol values is the investigational choice for this condition. Why is the investigational choice? Because you can see at 12 o'clock in the night, the cortisol values are the least, and in patients of Cushing syndrome, these values will persistently remain elevated. But you can see that the 12 a.m. spike will be like 12 a.m. dip would not be present. So the best test for diagnosis is midnight salivary cortisol. If he says what is the first test to be done, then first test to be done, the screening test would be answered by US 24-hour urinary cortisol values. I'll zoom into the table a little more. If he says what is the first test to be done, it is a 24-hour urinary cortisol. After this, the second test that is done is called as DOT. DOT stands for dexamethasone overnight test. In this, you will be giving 1 milligram Dexona tablet to the patient at 11 p.m. in the night. And normally, if you would dexamethasone, your cortisol values will get suppressed. But you can't suppress a lung cancer. You can't suppress ectopic source. So therefore, in this particular patient, the plasma cortisol values will be more than 50. That value is not important, 50. But that is just to explain to you that in dexamethasone overnight test in a normal person, DOT test, normal person like you and me, cortisol value can be suppressed at 8 a.m. But in this case, there will be no suppression present. After which we will be doing is a investigational choice. हाँ, यही तो बात है ना कि दो ही ऐसे कंडीशन होती है जहां पे रात में टेस्टिंग करते हैं, वरना तो एंडो मतलब नॉर्मली तो सुबह सुबह टेस्टिंग करते हैं ना, पेशेंट कहते हैं रात को आगे परेशान करने के लिए. Normally, there are only two situations where at night you are doing testing in a patient. One of them is at the moment like midnight salivary cortisol would be done. Otherwise, like all tests are done at daytime only in the hospital. Okay. Then subsequently, if the reports of this are not very conclusive, midnight salivary cortisol values should be more than 2 times of normal. If it is not, then we go in for low dose dexamethasone. So between low dose and dexamethasone, if you have to compare, then answer is low dose dexamethasone suppression test. I repeat my statement. If he says low dose dexamethasone suppression test में क्या करते हैं, so you will be giving like 0. In this case 0.5 milligram tablet will be given 4 times a day for 2 days. And you will be subsequently like checking plasma cortisol value, which will still be more than 50. Earlier you were giving one tablet only. Now you are giving it 0.5 milligram tablet 6 hourly for a continuous suppression, and still the plasma cortisol is elevated. So that gives more credibility to your diagnosis. So we have is a test called as low dose dexamethasone suppression test, which is more accurate as compared to dexamethasone overnight test. And when do you do a high dose dexamethasone test? Then high dose dexamethasone test is done subsequently for differentiation. High dose dexamethasone test is done for differentiation between lung cancer versus a pituitary adenoma. If it is lung cancer versus, if he specifically says what test is done to differentiate between whether it is a pituitary adenoma or whether it is going to be ectopic source of ACTH, then it is high dose dexamethasone test. So it is for cause detection that we'll be doing. The final summary is like this. There are 4 points to be remembered. Screening test is 24-hour urinary cortisol. Investigational choices, midnight salivary cortisol. Between low dose and high dose dexamethasone, if he says which is used to differentiate between ectopic source versus the endogenous cause, that is pituitary adenoma, then your answer would be given as high dose dexamethasone. Once you get these 3 concepts right, then I'll add 2 more to your vocabulary. That is ACTH independent Cushing syndrome. Independent means that there is an autonomous tumor in the adrenal gland. There is an autonomous tumor in the second layer of the gland that is causing excess production of cortisol. So we will be doing a CT abdomen in a patient. And if he says what is the first test to be done in ACTH dependent Cushing syndrome, then he's talking about pituitary adenoma. So the first test will be answered as MRI. We'll repeat the questions once again. 5 concepts I want you to remember. That is, first is screening test 24-hour urinary cortisol. Investigational choice should be answered as midnight salivary cortisol values. High dose dexamethasone to difference between endogenous versus the ectopic source. These are three, and then two are ACTH dependent and independent. For independent, it is second layer of the gland, adrenal gland having a tumor, so CT abdomen. And for ACTH dependent is first a MRI pituitary, then is gonna be CRS test. That is to demonstrate that pituitary adenoma is causing excess production of ACTH, and then differentiation of this would be third, subsequently followed by high dose dexamethasone suppression test. So great guys, these are like the sequences which are to be remembered for these patients. And a question for you guys here, like what medicine can you be giving to this ectopic patient? There is a ectopic. We'll check ACTH values, no? If we say ACTH dependent or independent, it is ACTH values, no? If ACTH values are elevated, then we will say ACTH dependent. That means either it is lung cancer which is producing it, or it is pituitary adenoma. Plasma ACTH is the test that would be done, no? That is given in the flow chart, that this is gonna be this is in the flow chart. As you can see, ACTH values would be checked, and that would help in differentiation. Sir, you have to listen to this once again. The test that is done, low dose versus, वो तीन होते हैं ना, low dose dexamethasone suppression, high dose dexamethasone suppression, dexamethasone over test. अगर वो तीनों dexamethasone suppression test देते हैं और उनमें बोलता है क्या टेस्ट यूज करते हैं, then the answer is given as, वो यहाँ पे भी लिखा हुआ है, ये देखो. If further confirmation needed or decided, low dose dexamethasone. So I'll repeat my statement. DOT, overnight dexamethasone. लो डोज डेक्सोना, हाई डोज डेक्सोना. अगर वो डेक्सामेथासोन कंप्रेशन टेस्ट के बीच में कंपैरिजन करवाता है, देन इट इज गोना बी लो डोज डेक्सामेथासोन व्हिच इज यूज्ड फॉर कंफर्मेशन और डायग्नोसिस और द इन्वेस्टिगेशन चॉइस. बट अदरवाइज लाइक द मेन टेस्ट फॉर डायग्नोसिस वुड बी टू चेक द वैल्यू ऑफ cortisol. So check it out again, and you will be able to Prakash, you will be able to understand this relatively better. And if midnight salivary cortisol and low dose both is in the options, yes, Sanskar, then the answer is midnight salivary cortisol is the best test for diagnosis of this condition, because endocrinologically speaking, ACTH is least at 12 o'clock in the night, cortisol is least at 12 o'clock in the night. So if you are getting a spike here, then midnight salivary cortisol would be answered. Yes, ectopic ACTH, the drugs that we'll be using would be very good, Dr. Basak. It is drugs like metapyrone, it is drugs like mitotane. Yes. Ectopic ACTH, it will be difficult to remove the tumor ना, because वो फैल गया होगा ना. Ectopic ACTH means it is oat cell cancer which is contributing to this. So the cancer will have spread everywhere. So I will give chemotherapy to the patient. I will try to removing the tumor is not possible, because the oat cell cancer is one of the most aggressive malignancies. So it would have spread everywhere. So I want to give a medicine. Very good. Ketoconazole is another drug that can be given. That is what I was pointing out, that you need to give answers for medicines that will inhibit steroidogenesis. And suddenly the chat became filled with the correct answers there. Medicines that inhibit steroidogenesis are to be answered. So treatment alone cancer will be given. We'll give cisplatin, we'll be giving irinotecan, we'll handle the metastasis in a patient. But the main treatment is inhibition of steroidogenesis. Etomidate is okay, fine. Okay, fine. Adrenalytic drugs. No. We'll not be doing it, doctor. No. Okay, fine. Moving ahead in our discussion, the main aspects was to sensitize you to the diagnostic workup of these patients so that we can work out the answers very correctly. And next, what I'll discuss before you is a question which has been asked in the exam with respect to two double datas given. He mentioned smoker also, and then he mentioned that the guy is a mason by profession as well. And then he said that the spirometry shows a FEV1 of 80% and FEV1 FAC ratio 0.8. So I will expect answers from your side for the current question that I'm mentioning. Yes, guys. Yes, please flood the comment box. I'll wait for another 15 seconds. A 40-year-old cigarette smoker comes to the doctor. He's a mason by profession, and the FEV1 FAC report of the patient is showing this value of 0.8. Yes, waiting, guys. Continue. Guys, the concept here is that you don't base your diagnosis on smoker, you base your diagnosis on the FEV1 and FVC report, and the FEV1 FVC report of the patient is favoring restrictive lung disease, and cigarette smoking can also cause a interstitial lung disease in a patient. The correct answer for this is option number B. Do not answer COPD just because smoker is given, because even cigarette smokers may interstitial lung disease can be developing. Good answers from most of the people. Now please tell me the name of that restrictive lung disease which is caused by cigarette smoking. Yes, this is a restrictive pattern. That is why. Om Prakash, you're right. Siddharth, you're right. Yeah, you're right for this one. Yes. Which interstitial lung disease would be seen in a cigarette smoker? Yes, your answer would be given as, somebody mentioned it as DIP. I'll just clarify that. That is called as desquamative interstitial pneumonitis. Desquamative interstitial pneumonitis is the interstitial lung disease that would be seen in patients. He's a Mason, so he can have silicosis component also. Silicosis is again going to cause a restrictive lung disease in this person. That is one more possibility. I mean, he could be having coexistence of two things also, because a lot of these construction workers, they keep on smoking also, no? Lot of these construction workers, they keep on smoking because it is hard manual labor, so they can be having like DIP, and along with that, because he's a Mason, he can end up with silicosis component as well. Okay, moving to the next question. A 25-year-old guy had a bike accident, and then he's having multiple injuries and was hospitalized for last 1 week, and today he was discharged when he started having breathing trouble. So the nurse called you. She said, Dr. Saab, please have a look at this patient. And you noticed that the person was having this pulse rate to be increased. The BP was on the lower side. And then he's mentioning a loud S1 with a widespread second heart sound. So in this particular image, you can see a CT angiography that is given. And there is a huge clot bang in the middle of the pulmonary artery. This is causing interruption of blood flow into the lungs of the patient. And therefore, the answer for this particular question would be given as option number A, that is pulmonary thromboembolism. Why it is not ARDS is because ARDS will be having bilateral whiteout. The lungs will be totally white, whereas here the lung parenchyma is looking perfectly normal in this patient. Fat embolism is unlikely because GERD criteria are not getting satisfied. I mean, there is no mention of any petechiae in this case. There is no mention of any low GCS in this case. Considering that petechiae are not given, low GCS is not given, the answer of this question cannot be fat embolism. GERD criteria can be ruled out in this case. The GURD criteria, the major criteria is lung problem, that is breathing trouble. Then is going to be petechiae, which will be present in the axilla and the chest wall of the patient, and the CNS problem of this patient would be a low dysfunction. The answer for this particular question is CT angiography showing a pulmonary thromboembolism. Yeah, GERD criteria is not satisfied for this question. That is why. Let's move on to the next one. A COPD patient is brought with worsening of dyspnea. ABG is showing a acidosis, pH 7.32, PCO2 60. So arrows are going in opposite direction. That means it is respiratory acidosis, and bicarbonate is 30. So it is a chronic respiratory acidosis. How I know chronic? Because in acute respiratory acidosis, the compensation rule is 10:1. But in chronic, it is 10:4. So I'll repeat that again. For acute, for every 10-point increase in the value of carbon dioxide, 10-point increase in the value of carbon dioxide, bicarbonate increases by 1 point. But for every 10-point increase in carbon dioxide, if bicarbonate rises by 4 milliequivalents, then we call it chronic respiratory acidosis. The differentiating rule is 10:1 and 10:4. And because of the fact that my patient is lethargic, he's having a chronic respiratory acidosis, I need to get the CO2 out of the system. And the best way to get the CO2 out of the system in this patient is to put the patient on a BiPAP. So the treatment for this patient is non-invasive ventilation. In all patients of acute exacerbation of COPD, where there's a carbon dioxide retention occurring in a patient, it is non-invasive ventilation which is to be done. The only thing is you have to be careful about the fact that non-invasive ventilation cannot be done in those patients where the GCS of the patient is decreased. So if he was mentioning unconscious patient here, then his lethargy is a separate thing. Lethargy to yaar, I'm tired, so I'll be like lying in the bed. So that's not a problem. But if a person is like having low GCS, that is a contraindication. Or if there is any GI bleeding, then nebulization with salbutamol and ipratropium will open the airways, but it will not remove carbon dioxide. Now we need to put him on non-invasive ventilation using a tight-fitting face mask so that we can remove that extra carbon dioxide from the body. Nebulization, he might have taken it at home also. or he might have been given already for previous 1 hour in the casualty, but because you are having carbon dioxide retention, there's a risk of carbon dioxide narcosis. Every time there is a carbon dioxide narcosis, it is BiPAP to be used in a patient. Otherwise, nebulization is to be done for both asthmatics as well as COPD patients on admission, so that I can dilate the airways. So that is initial management, but not the treatment of choice. It is CO2 washout that needs to be done. Then we'll talk about pneumonia. The commonest cause for pneumonia in patients is pneumococcus, which is the same cause for development of bacterial bacterial meningitis as well. Though if the question differentiate between mixed versus compensation in an ABG, I think it's okay, fine. Since you asked it, so I'll just mention that and then I'll go forwards. So I'll be doing 2 ABG MCQs before you. One is pH of the patient, though I think in recent one-liners also I discussed it, but still let's just do it quickly here so that you guys are more comfortable with the answer. So I'm gonna give you 2 ABG reports and then we will be analyzing the 2 reports here, where the PCO2 of the patient is, let me say, 30 and the bicarbonate of the patient is, let me say, still 5. So some differences is what I've introduced in the 2 ABG reports before you. Or both of them are those of metabolic acidosis. You can see all the 3 arrows are going down, down, down. So it is metabolic acidosis in a patient. Even on the right hand side, all the 3 arrows are going down, down, down. So it is metabolic acidosis. Now what you will do is you will use the Winter's formula to calculate the expected PCO2 of the patient. The expected PCO2 of the patient is whatever is the bicarbonate value, to that you will be adding 15, and in this question you can see that 5 is the value given. So expected PCO2 of the patient is turning out to be 20 and the actual PCO2 of the patient is also 20. So if both the values are matching, if both the values are matching like the ones that I've shown at the moment, then you will say it is compensatory disorder. It is compensatory disorder. But if the two values are not matching like on the right hand side, then it means it is a mixed disorder occurring in a patient. So for the first report that I've shown, because it is gonna be compensation, so I'll be writing partially compensated. Why partially compensated? Because pH is not normal now. Bicarbonate is gradually, in this particular person, the kidney will gradually try to increase the bicarbonate value and will, in this particular case, the kidney will try to compensate for the metabolic acidosis by retaining bicarbonate, and at the same time making the patient do hyperventilation, Kussmaul breathing, and the Kussmaul breathing will help him in removing carbon dioxide from the body. So partially compensated metabolic acidosis is the first report that I mentioned, and I have addressed that in last month discussion of that one-liners that I've done. And my suggestion to you guys is at least these 2 videos and then the previous one-liner video that I took last month. If you are gonna check these out, a substantial part of your syllabus would be covered, because I agree medicine is a vast one, but this would be covering like almost 8 to 9 hours of hardcore data that would help you solve this question. On the right hand side, you can see that if I apply the formula bicarbonate plus 15, it will still turn out to be 20, but the two values are not matching. So here it is a mixed disorder, and this mixed disorder would be answered by me as metabolic acidosis with respiratory acidosis. So in all questions of metabolic acidosis, these mathematical rules are to be satisfied. Similarly, in respiratory acidosis, I told you the rule of 10:1 and 10:4. If that rule is satisfied, it is partially compensated. If the rule is not satisfied, you will still call it a mixed disorder rules. So it is just the application of these formulas which would help you identify, and most of the questions that we would be. Yes, because CO2 values are higher now. That is because CO2 is not here. It is not more than 45, but still it is higher than what it should be. No, that is the point. The diaphragm of this guy is not working adequately. That is why the CO2 30 agree is less than 35. The query a lot of people is it's not more than 45. How can you call it respiratory acidosis? I am saying 30 is more than 20, the mathematical value that I'll calculate here. So on a relative sense, it is still more, and therefore you would be able to understand this. These are like the compensation mathematical formula is the one that is to be deployed. Okay, fine. Amit, I think I was able to get this point across. What if the value is less than 20? Yeah, I'm okay with that. If the compensation is working more than normal, I'm happy. I'll still call it partially compensated, right? If he's breathing faster and because he's anxious, I'm okay with it. But if he's not breathing faster than what he should be, that is a cause of concern. So our role is to take up the pathology. Now, if somebody is breathing faster and there is an overcompensation occurring, okay, never a problem. But if the guy is not compensating adequately, it's a cause of concern, because here I need to check now that the diaphragm is not working in a patient. So in those circumstances, like there could be hypokalemia. So I might have to correct the hypokalemia component of the patient. Okay, coming back to the agenda for community, for any patient who's having community acquired pneumonia, alcoholics, it is always going to be answered as Klebsiella pneumoniae. Yes, Sultan. You have to use the same formula. You have to use the same formula in metabolic. All MCQs are metabolic alkalosis and acidosis. It is Winter's formula to be used. And in respiratory acidosis, 10 is to 1 rule. In respiratory alkalosis, 10 is to 2 rule. In respiratory alkalosis, carbon dioxide will go by 10 points and bicarbonate decrease by 2 points. In 10 is to 1, carbon dioxide will increase by 10 points and bicarbonate rise by 1 point. So the rules are Winter's formula is uniform plus 15 for bicarbonate value for both metabolic acidosis and alkalosis. For respiratory acidosis, it is 10 is to 1 rule. For respiratory alkalosis, it is 10 is to 2 rule. Okay, quick comments here. Ventilator associated pneumonia. The leading cause would be answered as Pseudomonas. Tell me the name of culture media for Pseudomonas aeruginosa. Selective media for Pseudomonas aeruginosa, like we have taken bronchoalveolar lavage of this patient. Yes, Pseudomonas and Acinetobacter are the two organisms. We have taken a bronchoalveolar lavage of this patient. What is the name of the selective media? We will be using cetrimide agar. Tell me the antibiotic of choice for Pseudomonas aeruginosa. Yes, perfect. Cetrimide agar. Tell me the drug of choice for management of this case of Pseudomonas pneumonia. Yes, guys. Ceftazidime तो नहीं होता ना, या piperacillin tazobactam is a good answer. The first answer would be given as meropenem, and the second one we can use is piptaz, that is piperacillin and tazobactam for the patient. So yeah. It is piptaz, that's the second best answer, or meropenem can be used for management of ventilator associated pneumonia. Then is nosocomial pneumonia. Here I would also like to mention that for cystic fibrosis patients in the first 10 years of life, the leading cause of pneumonia is Staph aureus. But in cystic fibrosis patients after 10 years of life, it is going to be answered as Pseudomonas. So do check out the age in the MCQ before you comment on the final answer in MCQs of cystic fibrosis. बच्चे आजकल सफ्टाजिडीम से तो रेजिस्टेंस है ना, मल्टी, और आईसीयू में तो मल्टी ड्रग रेजिस्टेंस ही होगा. In ICU, there would be multi-drug resistance mainly present. So therefore, it is meropenem and piperacillin tazobactam that would be used. Yeah, Burkholderia cepacia is also an organism that would be used contributing to pneumonia in cystic fibrosis patients. Or yeah, specific, not exactly specific, but then it's like after Pseudomonas, that's the second most common organism. How do we differentiate between the two, the culture na? Because in Burkholderia cepacia, the colonies will be totally pink in color. And in Pseudomonas, it will be having a bluish green color around them. So we need to differentiate microbiologically whether it is Pseudomonas or Acinetobacter, but Pseudomonas, or whether it is Burkholderia cepacia. Burkholderia will be having pink colonies. Okay, nosocomial pneumonia is gonna be Staph aureus. Usually, like the cutoff taken will be more than 48 hours. The radiological finding in this case would be a pneumatocele, and this pneumatocele can exhibit a rupture also. So in case of a fact that he says that a Staph aureus pneumonia patient is having a pneumothorax, then it is usually a pneumatocele rupture that will be contributing to development of secondary pneumothorax in this patient. Sudden onset breathing difficulty in a Staph aureus pneumonia patient. Sudden onset worsening of breathing difficulty will be present in pneumonia, but further increase of breathing difficulty indicates that the pneumatocele has ruptured in this patient. Either it is MRSA or yeah, that is what is happening. Cystic fibrosis में तो पहले तो Staph aureus से निकल के आ रहा है ना, and then after that it is like later on it is coming as Pseudomonas. So initially it will turn out to be like mainly Staph aureus only, and subsequently Pseudomonas. Okay. Now for Staph aureus pneumonia, antibiotics, please quickly mention the antibiotic of choice for Staph aureus. Whether it is MRSA or VRSA pneumonia, standard treatment would be given in the patient. Pneumothorax will contribute to absent breath sounds. Antibiotic that you would be giving for like MRSA or VRSA here, mostly will be a VRSA, right? No, vancomycin से तो नहीं काम चलेगा ना. ओके, सो डैप्टोमाइसिन देंगे या लिनेजुलिड देंगे, ये तो बहुत बार बताया हुआ है यार. आई थिंक दिस इज लाइक अ वेरी कॉमन क्वेश्चन दैट वी ऑलवेज डिस्कस, that whether it is VRSA or MRSA, because most of the time like even we are using linezolid for MRSA also nowadays. So linezolid is useful for pneumonia. If it was MRSA, if it was Staph aureus sepsis, if it was CLABSI. What is CLABSI, by the way? What is CLABSI? CLABSI? Full form of CLABSI, please. Yeah, if it is pneumonia, then linezolid. What is CLABSI? CLABSI is central line associated bloodstream infection. CLABSI is central line associated bloodstream infection. So if it is CLABSI caused by Staph aureus, then it is daptomycin that would be used. Otherwise, it is the standard data which is to be followed here. So for Staph aureus, it is daptomycin. Then alcoholic with red currant sputum has already been discussed. It would be Klebsiella pneumoniae. There would be a bulging fissure sign in this patient. There can be a cavity formation. There can be a lung abscess developing in this patient, though the most common cause of lung abscess is Staph aureus, but then even Klebsiella pneumoniae can contribute to it. Most of the time it would be a red currant jelly sputum, that's the key word, and then he will use this as a prop to mention the name of the bacteria, that is Friedlander's bacillus. That is the alternative term to describe the organism contributing to this, and therefore the infection is called as Klebsiella pneumoniae. The leading organism in a COPD patient or smoking patient would be answered as Haemophilus influenzae. You guys can mention the next one. You've been silent for a while. Comatose patient, leading organism contributing to pneumonia. Yeah, that's a good one. Comatose patient, drug intoxication. Yes. Comatose patient is gonna be anaerobic pneumonia. This will most of the time be contributing to extensive necrotizing pneumonia and can cause a lung abscess in an individual. And if he says what is the treatment to be done in this patient, you guys can quickly comment here. Antibiotic or choice for anaerobic pneumonia would be, yeah, it is clindamycin that would be used in this case. So this is pretty straightforward a slide as far as the pneumonia based organisms are concerned. You can also see in the x-ray bulging fissure sign. You can also see like the air fluid level that is present. So the chest x-ray of this patient is revealing a presence of a lung abscess. This could be a presentation with any neurodegenerative disorder where there is like pus at the bottom and there would be air on the top. So this is like an air fluid level present. Next is a question which is a hot favorite where you can see that ping pong ball appearance. I think madam would have also talked about it, especially with respect to AIDS positive patient with CD4 count being low with bilateral infiltrates present. That would be pneumocystis jirovecii as a cause of pneumonia in this case. The name of the stain I think is also very, very clear. The stain would be called as gomorimethapine. It is the ping pong ball appearance that you are seeing in this case. Because this infection is common at CD4 count less than 200, so we can start prophylaxis in advance only if the CD4 count is more than 200. And the antibiotic that would be used is like trimethoprim and sulfamethoxazole. The other name for that would be given as cotrimoxazole. It is useful for both treatment as well as prevention for this patient. The main keyword for pneumocystis jirovecii will be either gomorimethapine on the bronchoalveolar lavage of the patient. If this is not given, then what will be given will be findings like bilateral crepitations, or he might mention finding of increased alveolar arterial gradient, A minus A. Alveolar arterial gradient would be increased. I mean, don't answer jirovecii pneumonia if these informations of gomorimethapine, Krebs and alveolar arterial gradient is not mentioned. Like a question that came in the paper previously was having AIDS patient with bronchial breathing. If a AIDS patient is having bronchial breathing and dullness to percussion, then in those circumstances, the answer for this particular case, even if it is AIDS patient with bronchial breathing and dullness to percussion will change. In those circumstances, the answer would still be given as pneumococcus. So word of caution here that the most common cause of pneumonia in AIDS patients is pneumococcal pneumonia, because these people will be living in the community. The number one cause of pneumonia, if CD4 count is less than 200, I understand is pneumocystis jirovecii. But if the question simply says like overall number one cause of pneumonia in an AIDS patient, especially if he mentions bronchial breathing and dullness to percussion, it is pneumococcus. Then is that question on Legionella. Legionella will always be causing SIADH. Legionella pneumophila, Legionnaires disease will cause SIADH. SIADH will draw water in the body, so it will cause dilutional hyponatremia. And because of this hyponatremia component, what can happen in this patient is development of seizures. This is very, very peculiar that pneumonia patient is having seizures. I mean, pneumonia patient having seizures, it looks like it is hypoxia which is contributing to it. But here you can see it is not hypoxia. It is electrolyte imbalance which is contributing to development of seizures. So that is why this discussion is important, because we will be calling it atypical pneumonia. So one of the very classical examples of atypical pneumonia where we use azithromycin for management is answered as Legionella pneumophila. Yes, confusion can be present, seizures can be present, transmission via AC ducts and air cooler can be present. That's understandable. Or like this guy went on a ship cruise, and while he's on a ship cruise, this guy is taking a bath, and due to inhalation of the water, normally water causes diarrhea, waterborne illnesses causes diarrhea, but I'm teaching you a waterborne lung disease. That waterborne, that mist of water particles, no, that will be containing this bacteria, the stale water, and this can cause Legionnaires disease to develop in a patient. That is confusion, and can contribute to development of issues in this patient. So it is azithromycin that would be used for management of this patient. Then is CURB 65 score. This again you are aware of. If the score of the patient is between 0 to 1, where 1 will mean only age is parameter, only age is parameter. If the score of the patient is 0 to 1, in those circumstances we can be doing is a OPD basis treatment of this patient. But if the score is between 1 to 2, what I mean by 1 to 2 is 1 is coming 2 times, but age is not a parameter. Like suppose patient is having respiratory rate of more than 30, then it is the cause of concern. Then we will be using is IPD. If the score is turning out to be more than 2, then it has to be ICU based care in a patient, and that is just a the apps have to make it sound sophisticated, so they're saying CRB score, because the analysis is still the same. Whether it says CURB or whether they say CRB score, the analysis will still be the same. You have to go by Harrison for the interpretation for this one, and not what is given on up to date, because I don't think so that they'll be using up to date as a resource for, that's the reference that various apps would be giving. Up to date is not going to be used by the examiner to frame a question. So we'll go by like the standard reference that is given in Harrison only. Harrison, the current edition that is going on, still mentions that CURB score in a patient. The update is CRB only, but the interpretation still remains the same. The logistics are understandable. Blood urea nitrogen report may not be available immediately. That will mean delay in decision making, because if you will send the sample to the lab report in emergency, it will still take some time. So rest is understandable. Confusion, blood urea nitrogen elevation, respiratory rate, blood pressure values are less than 90/60, and age of the patient more than 65. But this is the interpretation that is present. If age is more than 70 years of age, no, if the guy is, let me say, retired from Indian Army, and he does a jogging every single day, and the age is more than 65, I'll not admit the guy. No, that is what Harrison is saying. You can say with a score of 1 or 2, patient should be hospitalized unless the score is entirely attributed to age more than 65 years of age. This is the line on which the question of previous year was formulated. Like if the man is 70 years of age and he's like fit and fine, doesn't have comorbidities, no diabetes, no hypertension, no stents in the heart, he goes for a jog every single day, because of pneumonia is not going now, but then there is no need for hospitalization. But yes, if it is a 60-year-old man with respiratory rate of 36, you will admit the guy. Age 70-year-old man, respiratory rate 20, I'll not admit. 60-year-old guy, he's not satisfying the criteria of 65 years. Na? I'll write it down. Like I gave two situations. 70-year-old man is totally oriented in time, space and person, no confusion. The respiratory rate of the patient is 20 per minute, and the blood pressure of the patient is, let me say, 120/80. I can manage the patient at home only. But suppose I say patient is 60 years of age and the respiratory rate of the patient is 36 per minute, and the blood pressure of the patient is, let me say, 90/60. That is a cause of concern, no? So I will, it's the age alone is not a criteria, guys. Age alone is not a criteria. So in 1 to 2, age is not included. In 1 to 2, it is age that is not included. That is what is written. Now, with a score of 1 to 2, patient should be hospitalized unless the score is entirely or in part attributed to age, in which hospitalization may not be necessary. This is line to line. I've kept the table from Harrison, and that is what the question in the previous year was created. So I've given you two scenarios, scenario 1 and scenario number 2. And in scenario number 2, because the patient is younger, but respiratory rate is higher and the BP is on the lower side. So that this is the guy whom I will be sending in for hospitalization. I mean, this guy will be requiring intravenous treatment, in fact, because the hypertension part is coming very severe, and because of the hypertension component, because there would be cerebral ischemia, so confusion component can also start coming up in the patient. Anyway, I mean, if patient is disoriented in time, space, and person, you anyway have to keep in ICU. Suppose I say 50-year-old guy with pneumonia but is disoriented in time, space, and person, then I'll not even I mean, 50-year-old man, right? And he should be fit and fine. He's not satisfying CRB 65. So even in those circumstances, what I'll do in that case is like if he's 60 years of age and he's disoriented, I'll directly admit him to intensive care unit. Okay, fine guys, I think we can move ahead for the treatment of these patients. And as far as the treatment is concerned, if the score of the patient is between 0 to 1, that is with the age being taken into consideration, then in those circumstances, what we have to do is start the patient on amoxicillin, and second, we can start the patient on azithromycin. So amoxicillin, azithromycin are the drugs that will be useful for management of this patient. But if there is mention of comorbidities in a patient, then it is amoxicillin with clavulanic acid. You can see amoxicillin with clavulanic acid with a macrolide that would be used. So the only difference in this scenario would be like, I'll just write it here also superiorly. For a score between 0 to 1, if in a question comorbidity is given in the question versus comorbidity is not given in a question, the answer will change. If it is gonna be absence of comorbidity, I can be using amoxicillin with azithromycin for the patient. If it is gonna be with comorbidity, like he's having stents in the heart, then I can be using amoxiclav, and along with amoxiclav, azithromycin. So it's a slight change that you are using Augmentin in this case. That's the only subtle difference that is coming. But if I increase the scores to between 1 to 2, then it is intravenous management that needs to be given. And in intravenous management, though there are multiple protocols that I'll discuss, most of the time we'll be using is like yeah, we can give ceftriaxone, Anshuman. We can give ceftriaxone with, I mean, amoxicefalosporins are like cousin brother of penicillin only, no? So ceftriaxone can be used also. So yeah, but if it is a score elevated, Anshuman, you are right in your values. I mean, I can give ceftriaxone with azithromycin in the patient also. But then if it is like 1 to 2, it is better to give respiratory fluoroquinolones for this individual. Doxycycline is in place of doxycycline is in place of azithromycin, na? It is for atypical organism. One is coverage for typical, second is for atypical. No? So you can see a or here. It is macrolide or doxycycline that would be used. So either the two can be used, and more people tend to prefer azithromycin in a patient. So okay, yeah, but you can see, like, if it is a patient who's having comorbidities, then amoxiclav can be plain. Amoxicillin is for if there is no comorbidities, if there is no antibiotic resistance. No, so this word will be given in the question. No, if he says no, like patient is not having any stents in the heart, there is no diabetes mellitus, there is no hypertension, he has never been admitted to the hospital, and is in a district where resistance is not present, then it is the standard treatment amoxi with azithromycin. But if it's gonna be a high prevalence of antibiotic with comorbidities given in the question, then you will change it to amoxiclav, or it is cephalosporin that can be used in a patient, or we can do monotherapy with respiratory fluoroquinolones. And as far as the extreme right hand side is concerned, if it is going to be like I would say disease severity is increased, what would you do in those circumstances? We can be using is respiratory fluoroquinolone. So majority of questions that have come in the previous session for, let me say, a case where the score was turning out to be 2 and an IPD based treatment had to be given, it is either beta-lactam with macrolide, that initially somebody was saying that okay, we can be using like ceftriaxone and we can be using azithromycin, that is one, or another option can be a single, we can be using respiratory fluoroquinolone. Between moxifloxacin and levofloxacin, there are three, any of the three can be used. It is levofloxacin, moxifloxacin, or gemifloxacin. Any of the three can be used in the patient. There is no distinction between them. It can be any of the three that can be used. It is levo, moxi, and then gemifloxacin to be used. That is IV respiratory fluoroquinolones in these patients for admission for cases of pneumonia. So CRB 65 as a score is not used to select the antibiotics. It is used to decide the need for hospitalization in a patient. And if there is a disorientation present in a patient, then straight away we have to shift the patient to intensive care unit. I mean, if a person is disoriented in time, space, and person, irrespective of the age group, we straight away have to admit him and put him into intensive care unit. Okay, so this was for curve 65 score that is asked. Now we'll focus on another topic that is asked, that is pneumothorax. And here, I'll first speak regarding tension pneumothorax. Tension word is only to be answered if in the question BP is unrecordable. Tension is only to be answered if the BP of the patient is unrecordable. If he just says that a person is having pneumothorax, which could be spontaneous pneumothorax also, then I mean the BP in that condition would usually not crash. So tension pneumothorax, the number one cause for this, as I explained in the earlier part of the discussion, would be barotrauma. The most common cause. It's not penetrating trauma, it is barotrauma that would be occurring. And what you can see in the image here at this particular point of time, yeah, it is barotrauma as I explained. And what you can see on this patient, it's not a penetrating trauma as I explained. And what you can see in the patient is lot of puffiness on the face, that is evidence of subcutaneous emphysema. Yes. Then you can also see that this person will start developing obstructive shock because the SVC and the IVC of the patient will get compressed. The compression of the superior vena cava and inferior vena cava, because air is going in the chest because of penetrating trauma in this particular case that I've shown, or maybe because of barotrauma, the pressure will increase so much that it will cause superior vena cava, inferior vena cava to get crushed. So therefore obstructive shock will occur, and this will cause elevated JVP. It will cause prominent neck veins in this individual, and therefore like the chances of this patient dying will be substantially increased. Road traffic accident without a crashing blood pressure. Yeah, road traffic accident with a crashing BP, then it can be tamponade also, no? Then the differentiation is based on the basis of presence or absence of breath sounds, no? Because in this particular case, what will be happening is that there would be absent breath sounds given. Whereas if it is cardiac tamponade, then he will mention regarding distant heart sounds in a patient and elevated JVP. But elevated JVP is a common thing between both of them, so I'll write here elevated JVP and hypotension. Elevated JVP and hypotension is a feature that is present in both of them. The differentiation is based on the fact of in tamponade it will be muffled heart sound, and on this it would be absent breath sounds. I mentioned two permutation combinations that can be given for a road traffic accident. If he gives you the left side data, then it is obviously hemopericardium and cardiac tamponade. Otherwise, it's gonna be like a tension pneumothorax that has occurred. Yeah, if he gives backstride, that is okay. But otherwise, like even if it doesn't write the word backstride, then the differentiation can anyway be kept. And then you can see evidence of subcutaneous emphysema because there is air in the muscles also. No, like you can see air present in the muscles of the chest wall, which is again a cause of concern because this means that there is an air leak happening in this patient. The lung has been injured and the air is escaping into the tissue spaces of the chest on the neck, and then will cause the puffiness of the face of this person also. So we will now mention regarding the steps which are to be done for management of this patient. The first and the foremost is in tension pneumothorax case, we will be answering as a wide bore needle. This wide bore needle will just cause little bit of air to escape. So therefore the pressure on the heart and the pressure on the SVC and IVC will become lesser. And this is gonna ensure that at least in this person, the BP will tend to go towards normal. It may not become normal, but at least it will tend to become normal. So in the fifth intercostal space in the mid axillary line, we'll be putting in a wide bore needle for this particular case. And after putting this wide bore needle, the next step that we'll be doing would be putting in a intercostal drainage tube. This intercostal drainage tube would be put in the triangle of safety. The boundaries of triangle of safety, anterally would be pectoralis major, back would be latissimus dorsi, inferiorly will be the fifth intercostal space, anteriorly pectoralis major, on the back is latissimus dorsi, inferiorly would be the fifth intercostal space. A chest tube would be inserted in this patient in the triangle of safety that would be anterior to the mid axillary line, and then we will be connecting this to a underwater sealed drainage, that is UWSD. So the complete treatment of this patient would be wide bore needle with a chest tube and then subsequently underwater sealed drainage. In one of the papers, I noticed that instead of writing like intercostal drainage tube, he just wrote it as a tube thoracostomy. Thoracotomy was also given and thoracostomy was also given. So it would be a tube thoracostomy that we are doing in this case. And this would be connected if there is going to be a there is a underwater sealed drainage present in this case. This underwater sealed drainage will, because even if it is a hydropneumothorax after trauma, we'll put two chest tubes, man. If it is hydropneumothorax, no, like there is hemo and there is, because after trauma there will be blood, so blood will go down and air will go up. So we'll put two tubes. One of the tubes will be facing upwards and the second tube tip will be facing downwards. So there are two tubes that are inserted from the same area, adjacent to each other. Two tubes would be inserted, and it can be one tube only, but then the problem is with a single tube you may not be able to evacuate a massive hemothorax in a person, because for hemothorax the tip of the tube should be downwards, and for hemo and for pneumo it is the tip of the tube should be facing upwards. So using a Kelly's forceps we can be putting two tubes with two different directions of the tip of the tube for complete evacuation of a pneumothorax. I think Anshuman, your query of that is satisfied. What is the number of the tube that you will be putting, by the way? Yeah, wide bore needle is understandable. That would be 14G to 16G needle that can be put. That is understandable. That can remove limited amount of air. Na? That wide bore needle will remove only limited amount of air. That is just enough to minimize the obstructive shock in a patient. So what is the number of the chest tube that you'll wear? Forceps I mentioned. Kelly's forceps, that third one will help you introduce the chest tube. You will break the pleural space. What is the number of the tube that you'll be using? Yes. Usually you'll ask the nurse for 32 French gauze. Usually it is a 32 French gauze that would be used. But if it is hemopneumothorax, then one would be 32, another can be 40. That 40 is for hemo. Mota, na, because the blood will get clotted in the patla wala tube, and 32 is okay for like the pneumo component. So if it is hemopneumothorax, two different tubes would be put. Usually it is like a 32 French gauze tube that would be put, and for hemo it is like a 40 wala tube that would be used for management. The main steps are wide bore needle followed by a chest tube followed by UWST, that is the underwater seal drainage. That's the common bag that you will be using in this particular case for management of these patients. And you can see a collection chamber here. This would be the site where the blood will usually be accumulating or water will be accumulating, and you will be noticing intermittent bubbling in this chamber. If there is a continuous bubbling, what does it indicate? Though it is covered in surgery, still if it is intermittent bubbling in this chamber, it is okay, that is normal. If it is continuous bubbling, what does it indicate? Yes guys. That upper border of the lower rib is the answer for thoracocentesis. Now here though you have to insert the needle. Anytime you are inserting a wide bore needle, it is always the upper border of the lower rib only. That is standard statement that is to be given to avoid the damage to the intercostal bundle, but it is more specific for thoracocentesis. Yes, it indicates a air leak. First answer is continuous bubbling indicates a air leak. If it is not air leak, then it can be a bronchopleural fistula also. So two differentials are to be remembered. If it is a continuous bubbling, either the connection of the bag with the tube is disconnected. So it is atmospheric air. ये वाला जो connection है ना ये lose हो गया है. तो atmospheric air is coming in. That is one possibility, continuous bubbling. Second can be a bronchopleural fistula developing in a patient. Those are the possibilities that can be present. But this was with respect to pneumothorax. But अगर COPD के patient में या स्टाफ ऑरियस निमोनिया के पेशेंट में न्यूमोथोरैक्स हो जाता, then we will be using the word secondary pneumothorax. Or patient had COVID-19 and after COVID-19 patient had pneumothorax. If there is a pre-existent lung disease in a patient and after lung disease, if a pneumothorax is occurring in a patient, then we call it secondary pneumothorax. That's because of the intrinsic damage already present in the lung of this patient. Like in this particular case also, he will notice that there is a hyperresonant percussion note in the chest. That is a standard feature for both types of pneumothorax, tension pneumothorax as well as secondary pneumothorax. Hyperresonant note will be seen, and he might mention the word absent air entry, or instead of, if the whole lung is gone, it is absent air entry, but only some part of the lung is damaged. Like in COPD, the big bulla is burst and only some part of the lung is damaged, the remaining part is okay. Then he may mention the word distant breath sounds also. So the point is, this is, I'm writing with a slash to say that in pneumothorax questions, even in secondary pneumothorax, you will be having hyperresonance. There would be absent air entry. The blood pressure in this patient is usually normal. It is not gonna crash. Question for you guys is, what is the treatment for patient of secondary pneumothorax? Overall, most common cause of pneumothorax is barotrauma again. Barotrauma, ventilator associated. Very good. Then in our case, our primary answer would be given as like needle aspiration. Very good. Like if it is needle aspiration of air, that would be done. Yes, conservative will also be done, but then conservative will, if it is like causing distress to a patient, if you are having like, I'm going to create a situation where person is having respiratory rate which is increased and the SpO2 of the patient is turning out to be like less than 88 or like even lesser in 80s, then it is a cause of concern. No, so we will have to go in for a needle aspiration affair. So very good. I'm having good answers here. That in those circumstances of secondary pneumothorax, it is needle aspiration, and along with this we will be requiring to put in a chest tube in even these patients also in the triangle of safety only. But in this case it will not be a wide bore needle. That would be word used would not be a wide bore needle. Here we will attach the needle to maybe a 100 ml syringe or 50 ml syringe and aspirate the air. So the word aspiration of air is to be kept, and this is totally different from the thoracocentesis that we shall be doing in the patient. So I think we are sorted as far as the aspect that I've highlighted before you. For any patient who's having COPD, or if it is going to be lung disease in a patient, then it is secondary pneumothorax that would be used. And if it's going to be like trauma contributing to it, or if it's like a barotrauma contributing to it, then it is tension pneumothorax, where there would be crushing of blood pressure in a patient. So pneumothorax as such, it would be perfectly fine. Needle aspiration at what intercostal space, depending on the location of the pneumothorax. This time the needle aspiration will not be based on, in this particular case, the site for needle aspiration will be dependent on the location of the pneumothorax now, because the bulla could be present anywhere in the lung. The bulla could be present and the air will tend to rise in this particular case. So most of the time, if it is upper part, we might be doing a second intercostal space. So it would be first ultrasound guided procedure. When we do a needle aspiration, we'll keep a probe on the side, and then in that needle, when we are inserting the needle, it will not be a simple needle. It will be attached to a syringe having saline, and you will see bubbles of air escaping from that area into that saline, which means that the patient is responding to your treatment, and then subsequently a chest tube would be inserted in this patient. So it is an ultrasound guided site in this case, because we can't predict here which part of the lung is getting affected, because I can't tell where Staph aureus will affect which part of the lung, which lobe of the lung, upper lobe, middle lobe. So in those circumstances, like you just have to answer it accordingly. Yes guys, I think that's the same approach. Bullas and blebs are only variation in size. I mean, if they're bigger, we call it bullas. If it is blebs, they're going to be relatively smaller. Then comes the issue of pleural effusion that they love to ask in the exam, in which you will be noticing a meniscus sign coming up with blunting of the costophrenic angle. And if it's going to be a straight line, then we will be calling it a hemopneumothorax or like a hydropneumothorax, as somebody put up in the chat initially. For hydropneumothorax, it is 2 chest tubes that would be required so that we can do a proper evacuation of the patient, or sometimes if it's not feasible, a single wide bore tube can be put so that at least the hemo component and subsequently the pneumo component can be reported. Okay. Moving ahead in our discussion, we will always study regarding criteria which are called as Leitz criteria. These again are important aspects to be remembered for differentiation between the Leitz criteria, that is transudate versus an exudate. And if the values are turning out to be more than in all of these, then you will say it is exudate. If it is less than, then it will be answered as transudate. Question for you guys here: what is the most common cause of transudative pleural effusion? Guys, focus on the discussion and you can let the distraction go away. What is the leading cause of transudative pleural effusion? Leading cause of transudative pleural effusion. Heart failure. No, transudative. Na bache, I asked transudative. Your focus went away. It is congestive heart failure. Congestive heart failure is the leading cause of transudative pleural effusion. It will cause bilateral, right? And if it says cause of unilateral massive effusion in a patient with cachexia, cachexia means always a cancer, then it is gonna be lung cancer. What is the most common lung cancer, by the way? Small cell, squamous cell, adenocarcinoma, large cell. Can I have answers, please? Which is the commonest lung cancer? Yes, guys. Yeah. Yes, it is adenocarcinoma of the lung, which is the most common one. So adenocarcinoma of the lung is the most common one. It's peripheral located now, so it will contribute to breathing difficulty in a patient. And for management of this malignant pleural effusion, what you will be doing is a pleurodesis in this particular case. But then Leitz criteria are like good aspects to be remembered. And comparison between pneumonia, pneumothorax, and pleural effusion is what I've tried to emphasize on this one. With bronchial breathing for pneumonia, for pleural effusion, it is stony dull percussion note. In fact, I should write it here. I mean, you would always be having the word written stony dull percussion. Then do not be surprised if he says bronchial breathing in a MCQ pleural effusion. Guys, at the upper level of the pleural effusion, wherever the pleural effusion is present ना, तो pleural effusion में जहाँ पे मैंने star mark लगाया वहाँ पे तो air entry will be reduced because the air is getting squeezed, but the upper border of the pleural effusion is having consolidation kind of finding, that is bronchial breathing. So bronchial breathing at the level of the effusion. bronchial breathing at the level of the effusion. He may not write the word at the level of infusion. He may just say bronchial breathing to throw you off the track. The learning point is that word stony will then help you in identification, because otherwise if I say dull percussion note and then I subsequently say bronchial breathing, it can be pneumonia also. Lots of time there can be pneumonia with pleural effusion also. So the key word is stony dull percussion note and bronchial breathing. If it is given, the answer would be given as pleural effusion, because pleural effusion can contribute to consolidation kind of a finding coming at the upper level of the pleural fluid. And if you put your stethoscope at this area where I'm putting the green marker, over this area, if you're putting a stethoscope, then there would be presence of reduced air entry. That is because the air is getting, lung is getting compressed by the water over the lung parenchyma. So all three should be present. I think stony dull percussion note, bronchial breathing, and then reduced air entry. The diagnosis would still be given as pleural effusion and not as pneumonia, because pneumonia has only bronchial breathing. Then it is a dull percussion note that is present, right? So that slight difference should be present. And in pneumonia, the air entry is normal. Pneumonia may pus is in the alveoli, na guys. There is no obstruction of the airway. So pneumonia may the air entry will be normal. So the differentiating features are the ones which I'm trying to highlight at the moment before you. Okay, let's do a question now, because we've done a bit of theory. A child is having a diarrhea with dehydration. The urine output is only 50 ml in the last 12 hours. His body is having extensive amount of swelling. So it's giving me a case of renal presentation. Swelling in the body and urine output is less because pani pee raha hai, but sharir se nikal to raha nahi hai. So there's swelling all over the body. The examination shows an anasarca with blood pressure of 120/80. Both same, Raj, both same, both cause whiteness in an X-ray. So it is just that if bronchograms are written as, in medicine we call it consolidation. Air bronchogram is the whiteness that is present in the X-ray. Okay, so in this particular case, there is an anasarca present, and you can notice the BP of this guy is elevated. So one thing is very sure, there is acute kidney injury. How do I know it is acute kidney injury? One, there is anuria. Second, there is edema. Third, there is hypertension, because if GFR will become less, then there will be RAS activation. So hypertension is present in the case. And then in this patient, LDH is normal, KFT is deranged, ultrasound shows the enlarged kidney. I'm waiting for your answers here. For hemolytic uremic syndrome as an answer, there should be mention of schistocytes in the MCQ. There is no mention of any schistocytes present. There is no mention of any previous infection. Hemolytic uremic syndrome is usually seen after an episode of diarrhea in a patient. Usually the bacteria which is responsible for hemolytic uremic syndrome is E. coli 0157H7. So answer cannot be A, because in A you would be having schistocytes and there should be preceding evidence of diarrhea or dysentery in an individual with infection with organism by the name of E. coli 0157H7. As far as acute glomerulonephritis is concerned, AGN is concerned, for acute glomerulonephritis to be present, we need to have presence of RBC casts. We need to have presence of low C3. C3 levels to become relatively lesser. If this is post streptococcal glomerulonephritis, RBC cast would be present, C3 levels would be less, and the kidney size in the case would be normal, whereas in this case you can notice that one kidney of the patient is enlarged. So the answer cannot be option number D. Now I'm left with acute interstitial nephritis and renal vein thrombosis. Acute interstitial nephritis is usually seen with antibiotics. Antibiotics that can contribute to it are like vancomycin, and another hint for acute interstitial nephritis is eosinophiluria. Guys, I am describing 4 topics in a single question. The hack for acute interstitial pneumonitis is patient is on antibiotic like vancomycin, and eosinophils in the urine will be present. I'll also write down conditions where eosinophils in the urine will be present, but AIN is one condition where eosinophils in the urine are present. It is not present here. The answer for this is simple RVT, renal vein thrombosis, where because of the obstruction of the renal vein, blood will come in the kidney but cannot go out. If blood will come in the kidney and will not go out, it will result in development of extreme amount of congestion, and therefore there would be an enlarged kidney that is present. So there is the key in this question, left-sided enlarged kidney. This is the only question where anuria will be associated with an enlarged kidney, because traditionally enlarged kidneys are hydronephrosis. Hydronephrosis is a chronic presentation, but here I'm telling you acute onset kidney dilation, whole kidney is dilated, not some part. Like hydronephrosis, some part is dilated only. Whole kidney is enlarged because renal vein thrombosis may obstruction will be there, and because of the obstruction present in this case, like blood is coming in the kidney but is not going out. So this would be RVT, that is renal vein thrombosis. Please comment in the chat box conditions where you get eosinophiluria. Quick comments in the chat box. Conditions where you can get eosinophiluria. In fact, schistosomiasis will be having eosinophils as well as RBCs in the urine. So, I mean, that parasitic infestation is still easily workable. What other conditions would be causing it? Eosinophils in the urine. Acute interstitial nephritis. Very good. AIN. Yes, parasite. Very good. Very good. Not exactly, doctor. Not exactly. In east अस्थमा में नहीं आते बच्चे. अस्थमा में नहीं आएंगे ना. अस्थमा में तो eosinophils in the urine नहीं आते ना. It is acute interstitial nephritis, and then would be another cause. Yes, yes, yes. The next cause for eosinophils in the urine is, वो तो ड्रग्स से ही होता है ना. ड्रग्स कॉज, drugs like PPI, drugs like vancomycin, they cause acute interstitial nephritis and renal failure. Same na, allergic interstitial nephritis and acute interstitial nephritis is same na. Whether I say allergic interstitial nephritis or whether I say acute interstitial nephritis, they are different terminologies. Guys, the third condition that will be causing development of eosinophiluria is atheroembolic kidney disease. Now let me explain this to you, what I mean by atheroembolic kidney disease. But this is again a very good question that can be asked to you. The atheroembolic kidney disease presentation will be given like this. The patient is undergoing a cath lab procedure. Like this patient came to the hospital today because the doctor had advised him coronary angiography. Now when you are sending up the guide wire in the descending aorta, imagine this is the aorta, this is the iliac arteries, and there is a plaque. There is a plaque in the, I'll just draw it. This is renal arteries which are sending blood to the kidney, and there is a atherosclerotic plaque present here, like atherosclerotic plaque. Now when your guide wire, like your guide wire is going to go up like this. So when your guide wire is going up, it is scraping against this, and this will cause those cholesterol fragments. It will cause cholesterol fragments. I'll draw the cholesterol fragments in yellow to escape from the atherosclerotic plaque, and they'll go downstream into the renal artery of this patient, and they will block the small blood vessels in the renal artery. This cholesterol embolism that I'm teaching you, this is the renal artery while I'm doing coronary angiography, is what is called as atheroembolic kidney disease. So condition in which you are getting atheroembolic kidney disease is a cath lab procedure. During cath lab procedure, what is happening is that there is a atherosclerotic plaque which is fissured, atherosclerotic plaque which is injured, and because of the injury to the atherosclerotic plaque, there is a cholesterol embolism that is occurring to all the areas of the body, including the renal vasculature. This is what is called as atheroembolic kidney disease. In the question, you may not remember all of this, but still, like these are like eosinophils in the urine. There can be three possibilities: parasitic, acute interstitial nephritis, and atheroembolic kidney disease. Moving to the next question, he says 60-year-old patient is admitted with a diagnosis of low urine output and swelling all over the body. One is elevated, serum creatinine is elevated, ultrasound is showing a normal size kidney. He says which of the following is useful for differentiating acute kidney injury from chronic kidney disease? See, creatinine cannot differentiate. Creatinine can be elevated in both of them. Size of the kidney. You are aware of the fact that diabetic nephropathy mein, the kidney size can be enlarged also or can be normal also. In diabetes, diabetic nephropathy, and in amyloidosis, and in cases of focal segmental glomerulosclerosis, in all of these conditions, though the kidney is damaged, the size of the kidney is increased or can be normal. So the point is, we cannot use size of the kidney to differentiate whether it is acute kidney injury or whether it is chronic kidney injury. I understand that chronic kidney injury can sometimes be having a scarring of the kidney, and the scarring can then contribute to some kidneys to be smaller in size, like in chronic pyelonephritis, but not all cases. Sometimes kidney can be enlarged. Urine output again cannot differentiate. It is urinary albumin that will be used to differentiate. Every time we read about chronic kidney disease, we discuss grades of CKD, and along with grades, we also study regarding albuminuria. If you listen to my discussion on chronic kidney disease, and I'll just say this once again, we discuss them from G1 to G5. And along with G1 to G5, we also discuss albuminuria, that is A1, A2, A3. We do not have albuminuria in acute kidney injury, but albuminuria is a feature that is seen in chronic kidney disease. The definition of CKD, when you read that KDIGO guidelines, the first thing on the table is urinary albumin, that is A1, A2, and A3 values. So it is albumin that will help you in differentiating. Yes, EGFR with albumin is used for differentiating or identifying chronic kidney disease. As Dr. Shivani put it very correctly, it's called as albumin excretion rate, or is also called as urinary albumin creatinine ratio. Good job. Yeah, we can use rifle also, but instead of rifle, like it would be a better idea to use the KDIGO guidelines, which are more like having acceptability. Okay, moving ahead in our discussion. Okay, grades भी लिख लेते हैं यार, चलो grades की practice कर लेते हैं. You can do this activity before me. G3A बोल दो. G1 is GFR more than 90 ml per minute with presence of albuminuria. If he says, what is the earliest feature of diabetic nephropathy? If he says in a question, what is the earliest feature of diabetic nephropathy? Your answer would be given as hyperfiltration, because the kidney size will become bigger. So the GFR might come out to be even more than 125 ml per minute. The earliest feature is increase of GFR, that is written as hyperfiltration. The G1 value will be more than 90. Then coming to G2, it will be between 60 to 89 ml per minute. Then I think in NEET PG they asked G3B and G3A, maybe any of the two. I think two sessions were there, so any of the two values were asked. So for G3A, you have to remember values between 45 to 59. And here the value that you need to remember is between 30 to 44. And usually errors of judgment can come between this. Then it is easy, 15 to 29, and it is less than 59. Try doing this practice with me so that you are able to remember this information. I think most guys got it spot on, but अगर ये नहीं हुआ है, अगर आप सोच रहे हो ना खुद कर लोगे, नहीं होगा, अभी लिख लो इसको फटाफट से, फटाफट लिखो, नहीं लेथार्जी मत करना, इसको लिख लेना. ये आप इमेजिन करो कि नीट पीजी में पूरा किडनी पढ़े और क्वेश्चन क्या आया जो पहले पेज पे दिया था, G3A और G3B, है ना. मतलब सब रेयर चीज पढ़ लिया, थ्रोम्बोलिक किडनी डिजीज एंड एक्यूट इंटरस्टिशियल नेफ्राइटिस, एलर्जिक इंटरस्टिशियल नेफ्राइटिस, G3B पूछ लिया वो. Okay. Moving ahead, 6-month-old child is having polyuria and failure to thrive, and there is a hearing loss in the patient also. The blood pressure of the child is 60/40. There is signs of dehydration because there is going to be salt wasting present in a tubular disorder. This cannot be Conn syndrome because Conn syndrome does not have a hearing loss. Conn syndrome has hypertension with hypokalemic alkalosis. That is okay, but the patient is not having hypertension. 6-month-old baby, 60/40 is a okay BP. Hypokalemic alkalosis is a feature with hypertension, that is okay. But this patient to have Conn syndrome will not have a hearing loss present. Yes, guys, waiting for answers. Dent's disease is a condition in which there would be increased calcium loss in the urine. So there is increased risk of kidney stones. Dent's disease mainly causes nephrocalcinosis due to hypercalciuria. So I've ruled out two options for you guys. Between A and B, which condition will be having a chloride channel defect which is present in the inner ear also? Then it is Bartter syndrome. In Bartter syndrome, it is sodium potassium chloride co-transporter that is defective. One that is defective is sodium potassium chloride co-transporter. Along with this, another is chloride channel which is defective, and this chloride channel that is defective in the kidney is also present in the inner ear where there are presence of those cilia, and that can explain the development of deafness in this patient. So the hint in this question is, since the patient is having deafness, the answer in this question would be given as Bartter syndrome and not Gentleman syndrome. Bartter syndrome में deafness नहीं होती, पर Gentleman syndrome मतलब Bartter में deafness होती है और Gentleman में नहीं होती है. And otherwise the common things between the two will be metabolic alkalosis with hypokalemia seen in both of them, but the key word in this question is the presence of the deafness that is present. Okay, Dr. Biswas, you did a great job by writing down that data fast, and that is good practice. The answer to this is because there's a deafness given in the question, otherwise it would have been given as Gentleman syndrome. Okay, in a patient with electrical burns and stable vital signs, red color urine is observed. What will be the likely finding in this patient? So in electrical burns, there can be development of Alport can contribute to deafness also, but then there would be like hematuria with hematuria, sensorineural hearing loss, anterior lenticonus that would be present. Rhabdomyolysis is a presentation that can be seen with electrical burns, and because skeletal muscle is damaged, the damage is in the skeletal muscle. So that is the key word. Skeletal muscle damage will cause creatinine kinase levels to be elevated, that is CPK MM levels in this patient would turn out to be elevated. The reason for the red color urine, why is the urine red color, guys? Why is the urine of this patient red color? Yes, myoglobinuria. When the skeletal muscle will be damaged, myoglobin will come in the urine, and myoglobin is giving a reddish color. Hemoglobin gives a cola color discoloration. Hemoglobin gives a cola color discoloration and myoglobin will be giving a red color discoloration. Then nephrotic syndrome will be having three O's: massive proteinuria, hypoalbuminemia and edema. कोई क्वेश्चन टू यू गाइस, स्पॉट सैंपल में यूरिन प्रोटीन कितने से ज्यादा होगा? यूरिन प्रोटीन इन अ स्पॉट सैंपल शुड बी मोर देन हाउ मच to contribute to development of massive proteinuria? Yes, 3.5. वो 24 आवर का है ना. अगर मैं आपसे पूछता कि 24 आवर यूरिन में कितने से ज़्यादा होगा, तो आंसर 3.5 ग्राम्स पर डे होता है फॉर 24 आवर. बट स्पॉट सैंपल में इट विल बी मोर देन 2 ग्राम्स पर ग्राम ऑफ यूरिनरी क्रिएटिनिन. तो बस इस पॉइंट का ध्यान रखना. उसने पूछा मैसिव प्रोटीनूरिया का डेफिनेशन क्या है, तो स्पॉट सैंपल में इट इज नॉट मोर देन 3.5. इट इज नॉट मोर देन 3.5. इट इज मोर देन 2 ग्राम्स पर ग्राम ऑफ यूरिनरी क्रिएटिनिन. ओनली इफ ही सेज इट इज लाइक 24 आवर, it is 3.5. And then is hypoalbuminemia, where serum albumin will be turning out to be less than 2.5. Plus there's gonna be edema present. There's gonna be like periorbital edema. It will migrate to the genitals and then subsequently the feet of the patient, and there would be pedal edema developing. So diurnal variation of edema would be present, and these are essentials of diagnosis. What he can also do in the question is ask you about this 1 plus 2 plus 3 plus key mathematical values. So practice has to be done. At least minimum I expect you to remember is ki 4 plus proteinuria would be more than 1 gram of protein per deciliter. At least try to remember per deciliter in protein excretion, that is more than 1 gram. See, 1 is for 24 hours, then it is more than 5 grams. Then it is more than 5 grams. It is satisfying nephrotic syndrome definition. That's what we say in the word, no, 4 plus. But this value we are still able to remember. So he will ask you regarding milligram per deciliter instead of in 24 hours. So try, if whole is like a little cumbersome to remember, but at least the common values that I mentioned are like important ones. Especially the right hand side is the one which should be remembered. It is 30, then 100, then 300, and then 1000, and it is milligram per deciliter, because the remaining part we are still able to figure out as far as it is in grams per 24 hours is concerned. That is easy. I mean, we are able to figure it out. Nephrotic and subnephrotic proteinuria in 24 hours is more than 3.5 grams. That is why we always prefer 4 plus report for saying that it is nephrotic syndrome in a patient. Lipiduria, doctor, is not a essential criteria for diagnosis. It is only a presentation. What is the most common cause of nephrotic syndrome in newborn children? Leading cause of nephrotic in newborn children. Yes, guys. Yes. No, that is for child. That is for child. For child, it is minimal chain disease. But for neonate, it would not be answered as minimal chain disease. No? In a newborn baby, the leading cause would be answered as, yes, congenital nephrotic syndrome. This is what he wants to hear in the MCQ. That is Finnish variety of congenital nephrotic syndrome, in which there are defects in the form of nephrin and podosin, which is with respect to the following genes. If NPHS1 gene is defective, it is nephrin. If it is NPHS2 gene that is defective, it is going to be podosin. These two genes will be forming these proteins, and these proteins form an interlocking mechanism, and that interlocking mechanism is then responsible for ensuring that there is a interlocking mechanism prevents the proteinuria component from occurring. So in this case, the basement membrane is damaged, and that is why proteinuria would be present. Yes, something like a zipper that they'll be functioning for the Finnish variety. If it is a child, it is minimal chain disease. Leading cause of minimal chain disease is idiopathic, but which cancer of the lymph nodes do you get minimal chain disease? The leading cause of this is idiopathic. It can be seen with use of painkillers. There would be light microscopy is normal in this condition. That's why we call it minimal chain disease. No, because light microscopy is normal, but it is gonna be effacement of the food processes with respect to the podocytes, and the cancer which is associated with it is Hodgkin's lymphoma. The question was paraneoplastic manifestation. Minimal chain disease is the paraneoplastic manifestation of which cancer? It is Hodgkin's lymphoma. In adults, it is focal segmental glomerulosclerosis. The most common cause of this is idiopathic. Then they love to ask about HIV associated nephropathy as secondary causes. Then can be street drug, that is heroin. And then another causes for this can be Vesicoureteric reflux. Idiopathic, HIV, heroin, and vesicoureteric reflux are causes which are responsible for this. No, doctor, it is not MGN coming up any. Okay, fine. MGN would be coming up in the subsequent one, geriatric age group, that is membranous glomerulopathy. In membranous glomerulopathy, again, the causes that would be asked to you is for primary. Your answer would be given as an antibody that is called as PLAR. It is anti-phospholipase A2 receptor antibody that is responsible for the primary variety. But if it is going to be secondary, then one of the causes to be remembered for this can be connective tissue disorders like Hashimoto's thyroiditis, SLE, lupus ephesus. What is the type of kidney involvement seen in scleroderma, rheumatoid arthritis? कोई सा भी वो आपको लूपस या एसएलई या कोई सा भी कनेक्टिव टिश्यू डिसऑर्डर दे दे तो उसमें आपको मेम्ब्रेनस ग्लोमेरुलोपैथी इज टू बी आंसर्ड एंड देन इट कैन आल्सो बी सीन विद सॉलिड ऑर्गन ट्यूमर्स ऑल सॉलिड ऑर्गन ट्यूमर्स लाइक renal cell cancer etc उन सब के साथ में it can be membranous glomerulopathy that can be present. And as far as the electron microscopy finding in this particular patient is concerned, the electron microscopy finding for this patient, the electron microscopy, yeah, renal cell cancer, hepatocellular cancer, this would be, yes, spike and dome pattern. Yeah, spike and dome pattern is the electron microscopy finding that would be seen with respect to MGN, that is membranous glomerulopathy. The main word is spike and dome pattern. That is more than sufficient for you to get the question right for this. Otherwise, the causes are what I have mentioned before you. And for management of these patients, we might have to use rituximab, we might have to use cyclophosphamide, but in children, it is mainly steroids that is used. So, I mean, steroid responsive nephrotic syndrome is mainly minimal chain disease. Then other definitions that they have asked is for steroid resistance. Normally we give steroids at a dose of 1 milligram per kg. But if you're giving double dose steroids for 4 weeks and still the proteinuria is present, normally like you give when you give steroids, it is 1 milligram per kilogram in minimal chain disease. But if you're giving double dose steroids for a patient for more than 4 weeks and still the proteinuria is present, then you will be calling it steroid resistance. Can you comment on the drug of choice for steroid resistant nephrotic syndrome? Drug of choice for management of, yes guys, yes, yeah, we can be using cyclosporin or we can be using tacrolimus for the patient. There are two drugs that we can be using for steroid resistant nephrotic. Either it is tacrolimus or it is cyclosporin that would be used, not cyclophosphamide, doctor. That's what I wanted to bring to your attention. For steroid resistance, it is tacrolimus or cyclosporin that would be used. Now, if we contrast nephrotic with nephritic syndrome, you will notice a very characteristic manifestation. That is that there would be complete obliteration of the Bowman space. Like if you look at this representation, this is perfectly normal. You can see the Bowman space, you can see the normal glomerulus, you can see the capillaries, you can see the tubules which are having a very distinct lining. But if you check out the image on the right, you can see a lot of cellular infiltrate, blue cells which are present. So this is a cellular infiltrate that is present, and there is a complete obliteration of the Bowman space. And because of the complete obliteration of the Bowman space, there would be anuria described in this condition. That is for nephritic syndrome, usually post-streptococcal glomerulonephritis, because there is a immunofluorescence finding that is given here, that is of a starry sky appearance. These three images tell me that I am dealing with PSGN, that is post-infectious glomerulonephritis or post-streptococcal glomerulonephritis. Can you tell me the antibody seen here? Can you tell me the antibody responsible for PSGN? It will start type 3 hypersensitivity reaction. It is causing immune complexes. There is a immune complex mediated vasculitis. There is a damage to the basement membrane in the glomerulus that will cause hematuria. The presentation in this case would be cola color urine. And there would be anuria. There's a renal shutdown. Along with this, there would be hypertension, there would be edema, there can be encephalopathy as a presentation because kidney is shutting down, so these manifestations will occur. Yes, the antibodies in this case would be answered as anti-DNA ACE-B and anti-hyaluronidase antibody. Streptolysin O is like preferably not to be answered because that is for rheumatic fever, And for PSTN, it is like this antibody, and along with this, we'll also check the value C3. The C3 values will be lesser. There would be hematuria, there would be RBC casts described in a question, so that can that helps you identify the presentation of nephritic syndrome in the patient. Yeah, the encephalopathy part is due to two reasons: hypertensive encephalopathy, and second would be after hypertensive encephalopathy, it could be the second reason why there could be problems in this patient is the uremic encephalopathy component. Usually, like in adults only, if it's gonna be a poor response, that would be seen, because mostly it is a self improvement that is seen over a couple of days, and most of the cases improve with even without requirement of dialysis. So children have a spontaneous recovery and there is no need for any specific interventions. But if it is gonna be a adult and there is a persistently deranged KFT, that is when we might have to go for a kidney biopsy in this particular individual. Otherwise, we can diagnose the patient on clinical grounds only. Yeah, DNA ACE is the main antibody that is responsible for this. Okay, so here what I'll mention is a quick look at hemodialysis. Can you tell me the most common complication of hemodialysis? Yeah, we'll talk about bird beak in a while. Can you tell me quickly regarding acute kidney injury, which vein is used? Okay, I'll write it myself. Internal jugular vein and subclavian vein is used for doing hemodialysis in a patient. What is the biggest side effect of doing a hemodialysis? Your answer would be given as hypotension. The site would be internal jugular vein or subclavian vein. However, if the person is having chronic kidney disease, then from the non-dominant hand, we will be creating a fistula between the radial artery and the radial artery in the cephalic vein. This fistula that we create between the radial artery in the cephalic vein is called as Seminobrestia fistula. Question for you guys is, what is the most common complication of recurrent hemodialysis? You have made a Seminobrestia fistula, you're doing a dialysis 3 times per week. Every session for dialysis would be like for 4 hours. What is the leading complication that is seen with recurrent hemodialysis? Overall, most common complication of hemodialysis would be answered as hypotension. But if he says recurrent hemodialysis, because patient, it would be answered as accelerated atherosclerosis, that would be increased cardiovascular mortality. Other complications can be like dialysis dementia and dialysis disequilibrium. For dialysis dementia, you anyway know the question, it would be A beta 2 amyloid deposition. Then is dialysis disequilibrium, in which we might have to use mannitol in the patient on a short-term basis. Aggressive dialysis in a patient will cause a problem. Yes, and can cause a carpal tunnel syndrome as well. So just wanted to say a few aspects for hemodialysis. Indications for hemodialysis also I will be writing. Indications for hemodialysis would be like uremic pericarditis. Then can be uremic encephalopathy. Then can be uremic melena, which is causing hypotension. There's an internal bleeding occurring which is causing hypotension in a patient. Then is metabolic acidosis or hyperkalemia or hypertension that is refractory to medical treatment. Like you have already given calcium gluconate, you have already given insulin drip, but in spite of your treatment, the hyperkalemia is persisting, or in spite of giving soda bicarbonate, the treatment is working, then you have to use carpal tunnel syndrome. Can be again because of A beta 2 amyloid. Now that A beta 2 amyloid gets deposited in the carpal tunnel and gets deposited in the brain, so it can be dialysis dementia. All of these are like indications for dialysis. Another mnemonic that we use for it is AIOU mnemonic. That is one of them. Or like even without a mnemonic, you can work it out. Indications for hemodialysis would be one. Select out of the top 4 which of these is an absolute indication for dialysis. Like you get a call from your relative right now that some distant relative is requiring dialysis requirement, and they are saying decide now only and give us the permission, because otherwise it will be very late. So which of these patients, which of these is an absolute indication for dialysis? Options are uremic pericarditis, uremic encephalopathy, uremic melena with a bleed, hypotension. Which of these is like an immediate indication or absolute indication for dialysis? No guys, it is not encephalopathy. It is not encephalopathy. that is what I wanted to say. Uremic pericarditis can get converted into cardiac tamponade very soon, because uremic pericarditis implies that because uremia implies bleeding. So in fact, the two most important indications would be, if there's a hemodynamic instability occurring in this patient, I will first try to stabilize this particular patient by, if the BP is low, I might have to give blood transfusion to this patient. Hemoglobin would be low. But among the questions that I mentioned, absolute indication for dialysis should be answered by US. What I mentioned at the moment as uremic pericarditis, it looks very shocking, but uremic pericarditis in next 1 hour can translate into hemorrhagic cardiac tamponade. And because of this hemorrhagic cardiac tamponade, if the bleeding once will start, you can't do anything about it. You will remove that blood, again more blood will come. You remove that blood, more blood will come, because the coagulopathy component is not getting treated. So the absolute indication for dialysis would be uremic pericarditis, where like right now, right here, you will say, okay, fine, give the consent for hemodialysis. For encephalopathy, even if you do it tomorrow, or even if you do it late in the night, chalega. I mean, I am talking about a decision which is to be taken right now, right here. That is gonna be uremic pericarditis. Okay. This image is showing a smooth tapering. You have to tell me the cause. Please don't tell me the diagnosis. They gave an image like this and they said that there is a smooth tapering seen on a barium swallow, which is suggestive of the fact that person is having HLA-cardia. You have to tell me the cause for HLA-cardia. Yes, guys. Most common cause for most common cause of HLA-cardia. Yes, guys. Yeah, failure of relaxation. But why is this a failure of relaxation? Because there is a autoimmune process. No, the question was like not on the pathogenesis. He said it is autoimmunity that is responsible. Among the options, even HLA-cardia was given, but don't answer HLA-cardia, because HLA-cardia can be causing even heart involvement. It can cause mega heart, mega colon, and mega esophagus. HLA-cardia can cause a mega heart and a mega colon and a mega esophagus. So it is autoimmunity which is responsible for the loss of the ganglion, which is going to cause loss of this ganglion in the various plexuses, and therefore the LES tone will increase and aperistalsis will occur. But the breeding cause for HLA-cardia is autoimmunity. Ehlers myotomy laparoscopic with a partial fundoplication would be done in this case. Then is the image on Zenker diverticulum, where they can ask you about these two triangles, and I'll just put markings here. I mean, these two triangles, the one in red and the one in blue. So please comment on the red triangle first, which is below cricopharyngeus, which is one of the site from where Zenker diverticula could be occurring in a patient. Yeah, the most common cause is not Chagas disease. That's what I wanted to say. Yes, diverticulopexy would be done. Yeah, but the inferior triangle, नीचे वाला, एक ब्लू ट्राइंगल है और एक रेड ट्राइंगल है. तो ब्लू वाला जो ट्राइंगल है वो तो किलियंस ट्राइंगल होता है. जो ब्लू वाला ट्राइंगल है उसमें कोई इशू नहीं है. आई आस्क्ड फॉर द रेड वाला ट्राइंगल. Yes, guys, the red वाला triangle. Yes, that is called as Limmer's triangle. So diverticulopexy would be required in this patient for management if the size is persistently more, usually more than 4 centimeter. Otherwise, conservative management would be done, and there would be non-progressive dysphagia developing in this case. You can see that this is a very characteristic Zenker diverticulum, where like it's usually in the posterior wall, and this would be either outpouching, or it's a pseudo diverticulum that could be developing above or below the cricopharyngeus muscle in the Killian's triangle or in the Limmer's triangle. Then is the irregular filling defect, that is for carcinoma esophagus. This is just a recap from surgery that you guys are anyway aware of, because traditionally they give you carcinoma esophagus for the lower part where the irregular filling defect would be present, but I've shown in the middle part, which is more common. So this would be suggestive of a query squamous cell carcinoma. The dysphagia that is present in carcinoma esophagus will be progressive, but for Zenker diverticulum will be non-progressive, no doctor, because it is so chota sa. So from 3 to 4 centimeter or from 2 to 4 centimeter, it will not make too much of a difference. So I can say like 2 से 2.5 हो गया पहले, तो उसमें कोई पेशेंट को ज़्यादा डिफरेंस महसूस नहीं होगा as far as the progressive dysphagia part is concerned. So it would be non-progressive, but superiorly, like I've shown, a progressive dysphagia which will be associated with cachexia, and because the esophagus does not have a serosa, so the chances of spread will be very, very substantial. Then is another idiopathic condition that is called as diffuse esophageal spasm. The main test for this would be answered as esophageal manometry. वो esophageal manometry में mainly जो आपने याद रखना है, that is gonna be a lack of coordination between the peristaltic waves. I mean the whole of the esophagus is contracting in a single go. There is no definitive treatment for this condition. The barium swallow here is showing that corkscrew appearance, but this is very ideal. In half the cases, corkscrew may not be visible, so it is esophageal manometry that would be used to confirm the diagnosis in this case. And then what you can see is evidence of pneumomediastinum because there is air below the diaphragm. You can see gas under the diaphragm in the next image. You can see presence of gas below the heart. In fact, not under the diaphragm. This is gas under the heart, not gas with respect to under the diaphragm. He's having this vomiting and there's a pneumomediastinum, which means it is going to be Boyer-Haave syndrome. This cannot be malarious because malarious will be having hematemesis, that is vomiting of blood. So anyway, this can be ruled out. I mean, malarious will be having a self-limiting force. The BP will not crash. So therefore, it would be relatively easier for you to pick up. Questions on alcoholic and then subsequently vomiting can go in three directions. One possibility is that he will mention hematemesis, that is vomiting of blood, and along with this the BP of the patient will crash. Second is there is a hematemesis, the BP of the patient is not crashing. There is no crashing of the blood pressure of the patient. The third possibility is that he is giving you evidence of severe epigastric pain and rebound tenderness. And the fourth possibility is that after the vomiting presentation, he's saying that the patient is having chest pain because of chemical mediastinitis and there is presence of subcutaneous emphysema. So these are like four permutation combinations and any one of them can be put up. The first one that I described before you, where there is like hematemesis with hypotension, it means there is a portal hypertension in the patient, there is bleeding varices because of which the BP is becoming unrecordable. But if he just says vomiting and the BP of the patient is turning out to be normal, he is hemodynamically stable, then hemodynamic stability would be seen with malarious. It is a self-limiting force where there would be a tear in the lower esophageal sphincter. If it is epigastric pain with rebound tenderness, it is a peptic ulcer disease that we are suspecting in this guy. And if it is going to be chest pain with subcutaneous emphysema, then I'm thinking in terms of Boyer-Haave, then I'm thinking in terms of macular striate. And macular striate is a feature that is seen with Boyer-Haave syndrome. So what I have just covered here are 3-4 medical emergencies that can be seen with respect to alcoholic, with respect to vomiting, and then the various permutation combinations can be given. Yes, the last one is spot on, that is Boyer-Haave syndrome. The next case you can see is gas under the diaphragm. So this would be perforation peritonitis. Please tell me the cause, not the answer to the image. This is perforation peritonitis that I described. Why is it occurring? We can see gas under diaphragm in this case. Why is there a perforation peritonitis? Gas under diaphragm. Cause, please. Then you can see a small bowel obstruction. Let me know the cause. And then you can see a large bowel obstruction. And we have to identify the cause. Yes, guys. Yes, perforation peritonitis would be peptic ulcer disease. If it is small bowel obstruction, it would be adhesions. It could be adhesions of previous surgery or it could be congenital bands. Hollow viscous perforation. Yes, that would be a word written in the paper. Hollow viscous perf. That's okay. I mean, that's okay. Hollow viscous perforation caused by peptic ulcer disease. Yes. Then is adhesions and bands. Large bowel obstruction can be malignancy. Or it could be a sigmoid volvulus. Though for sigmoid volvulus, obviously that classical coffee bean appearance, and then there would be presence of that claw sign that would come up. Then they gave an image in which you can notice that it's a pipe stem colon with loss of hosturations. And the colon is super dilated. What I'm describing before is a case of ulcerative colitis. You are noticing two findings. One is complete loss of hosturations. Second, what you're noticing is a megacolon. So we're going to call it a toxic megacolon. In toxic megacolon, if perforation has not occurred, Then we give IV steroids to the patient, that is IV hydrocortisone. But if there is evidence of perforation, if there is evidence of free fluid in the peritoneal cavity, then it is surgery that would be required for this patient. So toxic megacolon can be managed conservatively in the absence of perforation. But if perforation is given in a question, yeah, the toxic megacolon, the bubble loop should be dilated more than 6 centimeter. टॉक्सिक मेगालोन क्वेश्चन देख के करना कि अगर उसमें बबल के लूप्स मोर देन 6 सेंटीमीटर डायलेटेड हैं पर परफोरेशन का एविडेंस नहीं है, तब तो इट इज हाइड्रोकोर्टिसोन, अदरवाइज इट इज सर्जरी दैट वुड बी रिक्वायर्ड फॉर द पेशेंट, दैट इज अ लेप्रोटमी. Then there's a classification also that is asked, and this classification will be categorizing the number of loose stools the person is having, bloody diarrhea. Along with this, weight of the patient. We'll talk about ESR, we'll talk about hemoglobin because low grade fever, because all these are inflammatory diseases. So true love and Witt's criteria. Yeah, can occur, Dr. Harshita Goyal. Yes, it can occur. But then firstly, we'll have to identify the cause. No, if there is a concomitant illness present, yeah, perforation can occur in a person. Like typhoid में तो हो ही सकता है. This is True Love and Witt's classification that has been shown. They asked about this with respect to the severity of ulcerative colitis. I mean, if they ask about extent of the disease, that it is gonna be standard Montreal classification. But severity of ulcerative colitis, एक है extent of the disease, till the sigmoid colon, till the splenic flexure, proximal to the sigmoid flexure. That is what is called as Montreal classification for the extent of the disease, the spread of the disease. But if it is gonna be severity of ulcerative colitis, it is True Love and Witt's criteria, where we take into consideration bloody stools per day, presence of fever, hemoglobin values in a person, ESR values in a patient, acute phase reactants can be checked like CRP. So that is like because it's an inflammatory disorder which will help in identification. Subacute interstitial obstruction can cause a perforation. Doc, टाइफाइड में तो अनलाइकली डॉक, ट्यूबरक्लोसिस है ना, टीबी. सब एक्यूट इंटस्टियल ऑब्स्ट्रक्शन का कॉज तो टीबी है. टीबी तो कुछ भी कर सकता है यार, देखो मतलब आई से लाइक टीबी कैसे ही बोलते हैं ना, इंडिया में तो टीबी कुछ भी कर सकता है. तो सब एक्यूट इंटस्टियल ऑब्स्ट्रक्शन का तो कॉज इंडिया में टीबी ही होता है ना, इलियोसिकल एरिया पे स्ट्रक्चर बन गया एंड देन यू कैन हैव अ परफोरेशन कंपोनेंट आल्सो प्रेजेंट इन अ पर्सन. ओके फाइन फाइन. आईबीडी में चलो आप लोग बता दो, ड्रग ऑफ चॉइस फॉर अल्सरेटिव कोलाइटिस बोल दो. व्हाट इज द ड्रग ऑफ चॉइस फॉर अल्सरेटिव कोलाइटिस? अल्सरेटिव कोलाइटिस के लिए अभी यार वो मैंने शायद ये रैपिड रिवीजन में बोला है या शायद, चलो मैं अभी बोल देता हूँ. अल्सरेटिव कोलाइटिस के लिए ना अभी आपने ड्रग ऑफ चॉइस सल्फासालाजीन आंसर नहीं करना है, नहीं करना है, इसको सुन लो प्लीज. अल्सरेटिव कोलाइटिस के लिए ना अभी रिसेंटली जस्ट जो मैं देख रहा था उसमें गाइडलाइंस में लिखा था कि सल्फासालाजीन के साथ में ना साइड इफेक्ट प्रोफाइल जो है वो काफ़ी ज़्यादा मतलब डिस्ट्रेस करता है एंड वी हैव बीन यूजिंग दिस ट्रीटमेंट फॉर अ वेरी लॉन्ग टाइम. ये चेंज ना बिल्कुल इतना प्रलॉन्ग प्रोनाउंस्ड है कि सुन के थोड़ा अजीब लगता है बिकॉज फॉर सो मेनी ईयर्स नो सल्फासालाजीन इज द ड्रग ऑफ चॉइस फॉर अल्सरेटिव कोलाइटिस दैट इट लुक्स वेरी शॉकिंग टू हियर दिस. दिस चेंज इज सेम लाइक जैसे डायबिटीज में मेटफॉर्मिन विद ग्लिपिजाइड की जगह पे मेटफॉर्मिन विद सिमाग्लूटाइड कर दिया. लाइक यू नो वी वर गिविंग मेटफॉर्मिन एंड वी वर गिविंग ग्लिपिजाइड टू सो मेनी पेशेंट, सडनली इट बिकम मेटफॉर्मिन विद semaglutide. Similarly, in ulcerative colitis, now he is saying that mesalamine should be given as the drug of choice for this patient. And then is Crohn's disease, where there would be there it is okay. चलो आप लोग बोलो ड्रग ऑफ चॉइस के लिए. या वी कैन बी यूजिंग मोनोक्लोनल एंटीबॉडीज डॉक्टर. मेनली इट इज टोफासिटिनिम ना, बिकॉज ओरल दे सकते हैं ना, तो टोफासिटिनिम, गोलीमुबैब आर द मॉलिक्यूल्स दैट कैन बी यूज्ड फॉर मैनेजमेंट ऑफ दिस पेशेंट, क्योंकि बाकी तो इजीली अवेलेबल भी नहीं होंगे ना. सो या देयर सो मेनी न्यू ड्रग्स यार, कोई लिमिट ही नहीं है मोनोक्लोनल एंटीबॉडीज में. बायोलॉजिकल्स में तो न्यू ड्रग्स आप कितने भी याद कर लो, लेकिन जो कॉमन जो टेक्स्ट बुक में दे रखे हैं पहले तो उनको मेंशन करोगे ना. तो इट इज लाइक बायोलॉजिकल्स में टोफासिटिनिम एंड गोलीमुबैब दैट कैन बी यूज्ड. एंड क्रॉन्स के लिए क्या देंगे, तो योर आंसर वुड बी दैट वी विल बी यूजिंग ब्यूडेसोनाइड. Budesonide is the drug of choice for Crohn's disease. That is budesonide ileal release preparation. Yes, guys. It is ileal release prep that would be given, not budesonide enema. Budesonide enema will be used for management of ulcerative colitis. It is a ileal release preparation of budesonide that would be used. And nowadays तो वो कहता है कि इन सब की जरूरत ही नहीं है, वो तो बोलता है सीधा इससे चालू करो बायोलॉजिकल से. अब ट्रीटमेंट विल ऑब्वियसली भी सुपर एक्सपेंसिव ना भाई. व्हेन विल आस्क द पेशेंट फॉर इन्फ्यूजन ऑफ इन्फ्लिक्सीमैब, गोलीमूवैब, ये सारी दवाइयों की बात करेंगे तो पेशेंट्स तो रोते हैं कि भाई ये इन्फ्यूजन तो इंजेक्शन महंगे होते हैं. पर वो कहता है व्हाई टू लेट द पेशेंट सफर लाइक ऑन अ लॉन्ग टर्म बेसिस एंड लास्ट में बायोलॉजिकल्स यूज करें. सो इन इंडिया बायोलॉजिकल्स इज द लास्ट रिजॉर्ट, बट इन द अमेरिकन बुक्स इट इज मेंशन्ड नाउ दैट बायोलॉजिकल्स शुड बी द फर्स्ट लाइन अप्रोच फॉर मैनेजमेंट ऑफ दिस पेशेंट. सो देयर इज अ बिट ऑफ डिस्पैरिटी. बट देन ओवरऑल अभी अगर वो बोल रहा है कि ये क्योंकि चेंज हो जाएगा ये वेरी सून ना, the drug of choice will not remain what I have told you. In very soon, like till your exam, this data is okay, but very soon, like in forthcoming couple of months and years, we will notice that for treatment of inflammatory bowel disease, because of the morbidity that the disease causes and it's a long-term illness, patient is sick for such a long time, so it is biologicals that would be coming. Yes, Dr. Sangeeta, that's what I'm saying. Indian approach is refractory is biologicals and the American approach is सीधा ही बायोलॉजिकल यूज करना शुरू कर दो कि भाई रिफ्रैक्टरी तक वेट क्यों करते हो, बिकॉज द डिजीज प्रोसेस इज वेरी मच. सो दिस वुड बी फॉर द IBD component, guys. And what we'll do next is we'll talk about the hepatology component. So again, a quick table here. Like it is surface antigen which is present, security system is missing, and then antibody to the core antigen is present in a patient, that is IgM class. अगर ये दोनों चीजें एक साथ प्रेजेंट होती हैं, दोनों एक साथ प्रेजेंट होती हैं तो बोलेंगे दिस इज acute hepatitis B. And if E antigen is present, that means the person will be highly infectious, high infectivity to the his or his sexual partner and to the doctor nurse who's handling the blood sample. अब उसका सिक्योरिटी सिस्टम सोता रहा. जैसे हमारे हॉस्पिटल में सिक्योरिटी गार्ड्स लगाते हैं, जब लोग हमसे लड़ने आते हैं वो सिक्योरिटी गार्ड सो रहे होते हैं तो फिर दिक्कत हो जाती है. तो वैसे ही यहाँ पे भी सिक्योरिटी गार्ड इज स्लीपिंग. सो दैट इज वाई द गाय हैज गॉट कन्वर्टेड इनटू क्रॉनिक हेपेटाइटिस बी. सो क्रॉनिक हेपेटाइटिस बी इज when there is surface antigen present and there is IgG class of antibody to the core antigen, and E antigen positive basically means high infectivity in a patient. Now this patient is suffering because the liver will get damaged. So I want you to compare that I will be starting treatment in this patient with help of tenofovir, and when I will give tenofovir to the patient, then the surface antigen of the patient will turn negative because I have killed the virus. Now the security guard has come up कि अरे सर मैं भी आ गया सलाम साहब. The security guard was sleeping on duty. That is why chronic hepatitis was there. Now he's trying to show a face. Oh, I am also there. No, I'll take care of you. But the damage is already done. So at that point of time, the security system is coming up at the moment. It is IgG class of antibody that is present, and the E antigen will turn negative. So what you can see is a recovery. This is a patient that I have therapeutically cured by using treatment, and the treatment that I given for this particular individual is tenofovir, or I can be using entecavir for this patient. After this, yes, हम used to हो जाते हैं, फिर उसके बाद में we are able to handle problems on our own only. Okay. So next is a report in which only one the security system will be given. If only security system is given, you will say vaccinated individual. If only security system is given, you will say vaccinated individual. If in the question only IgM class of antibody to the core antigen is given, if in the question only IgM class of antibody to the core antigen is given, then you will be answering this as gap period. The alternative name for gap period is window period. This is the time when surface antigen is disappearing and the security system is appearing. So between that, the only antibody that is present is the window period or the gap period IgM class of antibody. If only IgG class of antibody is present, then there can be two possibilities. One would be low level carrier. What I mean by low level carrier is that surface antigen has now become less in the body, so therefore it is below the detection threshold. Or the second possibility can be remote infection. I think this was a recent question. I think it was INISET or FMG exam, I don't recall. But in दोनों में से एक में था remote infection where everything was negative but the total immunoglobulin G count was given. So that's gonna be like a remote infection. But first answer in this case would be a low level carrier that I have mentioned. And then lastly, I can give a report in which all things are positive. This is very, very peculiar. This is very, very peculiar because patient can be having infection with two different serotypes. So security system is also there. And along with security system, earlier I was saying everything is negative, only antibody. Now you can see security system is also there and IgG class of antibody is also present. So if it is a infection with two different serotypes, like one of them is giving protection, other one the protection is not present. So if it is two serotypes causing infection simultaneously in an individual, Like in a IV drug user, no, they can keep on changing the groups. Or like in a sex worker, she got it from a different client. So if it is two serotypes infection in a patient, then security system will also be present and IgG class of antibody would also be present. And as far as window is concerned, no doctor, in the window period, the E antigen will usually tend to show a decline. So it will not be detectable. In the window period, only one antibody is present. The detection of window period is only IgM class of antibody to the core antigen. It is not the E antigen, because E antigen does not diagnose the infection. Another point why I am counteracting you is because E antigen can be absent in E antigen. This is a general statement that I'm mentioning. E antigen can be absent in pre-core mutant in certain strains which are found in especially Europe. उनमें E antigen express ही नहीं होता है. E antigen is absent in pre-core mutant. So E antigen can never be used for diagnosis of infection. It is only for infectivity component. This test is negative in the pre-core mutant format, which is the European strain of the virus. So we cannot use it for identification of anything. विंडो पीरियड में W का M उल्टा होता है, हाँ उससे याद कर लो. आई मीन गैप पीरियड है, विंडो पीरियड है, सो दैट IgM कैन बी यूज्ड फॉर दिस. दिस इज अ गुड इनपुट दैट यू मेंशनड. Okay, escape mutants are like where there would be a HBS mutation. Escape mutation में फिर then there would be like serological security system will be present and still surface antigen is present. That is the peculiarity of escape mutant. It will escape seroconversion by the security system, which is a dangerous thing to happen. Okay. Then is CPI for MELD score, where we will check the serum creatinine and the bilirubin and the international normalized ratio to decide the need for liver transplantation. Naser index is used in Wilson disease, where we will be using BIAT, BOIT, that is bilirubin, international normalized ratio, and then it is SGOT. BIAT का OT जो है, that is for the OT component, क्योंकि यहाँ SGPT आंसर हो सकता है. So Naser's index is for need for medical treatment. Like in Wilson disease, if the score is less than 7, then we will be starting the patient on chelator agent, that is trientine. And if the score of the patient is more than 9, then we will plan a liver transplantation for the case. So Naser's index and Child-Pugh score will be having bilirubin and INR common, but then there are 3 A's, and the A's would be as follows. It would be albumin, it would be ascites, and then it would be asterixis in a patient. That asterixis is mainly because of the ammonia concentration that would be rising in this patient. So the A component, this would be for APTT, that is it is international normalized ratio, which is, and then is asterixis. The learning point I wanted to say was APTT is not a part of the component of Child-Pugh score. The question was not a part of Child-Pugh score is APTT. It is A is for asterixis, the ammonia concentration, and it is not for like APTT. It is prothrombin time or international normalized ratio, which is a common parameter present here. So this would be like the common parameters that are used for deciding the need for liver transplantation. And let's look at this SAG values that should be remembered. The mnemonic for SAG for value less than 1.1 is TPN. TPN, T would be standing for tuberculosis, P would be for peritoneal carcinomatosis, N would be for nephrotic syndrome, and then is biliary leak, that can be remembered separately. But TPN as a mnemonic can be used to remember the manifestations of TB. Peritoneal carcinomatosis can be seen with stomach cancer or can be seen with colon cancer. Then N is for nephrotic syndrome, and then is a biliary leak. And if it is gonna be values less than more than 1.1, then ascitic protein is to be checked. Ascitic protein, if it is less, it means cirrhosis, because there is a fibrosis component that is occurring. So you just need to get the arrows right for the current data that I'm saying before you. If the SAG value is more than 1.1 and ascitic protein is less, it is cirrhosis. And second is late Budd-Chiari syndrome. In both of them, the common thing is because there is fibrosis present, that is why the ascitic protein is not being able to leak. But in early Budd-Chiari syndrome, because the protein values are elevated, because there is an increase in the hydrostatic pressure, in early Budd-Chiari syndrome, the value of ascitic food protein, why it is more than 2.5 is because there is an increased hydrostatic pressure. Same is the case with heart failure. Same is the case with constrictive pericarditis, sinusoidal obstructions. I mean, because of the increase of the hydrostatic pressure, more protein can leak. and that is why the serum protein value is more than 2.5, but if it is lesser, it indicates the presence of fibrosis in the patient. So this is again a table which is worth remembering, and the question said patient of liver cirrhosis is with massive ascites, which is the correct statement. So in this patient, serum albumin values would be more than 1.1, but ascitic fluid protein values would be less than 2.5. A word of caution for those sitting for ANICET exam in Budd-Chiari syndrome. Remember, the value of ascitic protein early will be turning out to be more, but in the late part will be less. Ulta hai, early part में more होगा, late part में less होगा because of the fibrosis part that would be coming up in the patient. Can somebody tell me the most common cause? Can you tell me the most common cause of Budd-Chiari syndrome? Budd-Chiari syndrome is thrombosis of the hepatic veins. At least through hepatic veins should be thrombosed. What is the most common cause of Budd-Chiari syndrome? Waiting for your answers, guys. Yes, guys. Okay, fine. Anybody else, if they can comment there? The most common cause of Budd-Chiari syndrome, guys, is a hematological disorder that is by the name of polycythemia vera. And the second is gonna be PNH, that is paroxysmal nocturnal hemoglobinuria. It is most common cause of Budd-Chiari syndrome is polycythemia vera. It is hematological causes, guys, which is to be remembered, and then a hemat cause which is to be remembered, which causes this presentation is Behçet's disease. Yes, PNH and polycythemia vera are two conditions where you could be having is Budd-Chiari syndrome, thrombosis of the hepatic veins will be occurring, and then you will be having manifestations like caput medusae. You could be having spider angiomas in a patient. Then is Terry's nails. You can notice the white nails that are present that are called as Terry nails, that is leukoonychia. And then there is palmar erythema. This was an image-based question. Please select between the four. I'm giving options here A, B, C, D. Which of the following indicates portal hypertension? I think a very easy question. Behçet's how? Behçet's में यार vasculitis होता ना? Behçet's में vasculitis होता है. Behçet's में तो cerebral venous thrombosis भी होता है. Behçet's is a vasculitis which causes ulcers on the genitals. It causes oroculogenital syndrome, but it can cause cortical only vasculitis. मैंने ये starting में भी बोला था. Only vasculitis that has a venous involvement is Behçet's disease. Otherwise, all vasculitis have arterial involvement, but Behçet's has a venous involvement, so they can be cerebral venous thrombosis. They can be female patient with venous stroke, or there could be like Budd-Chiari syndrome occurring in a patient. Yes, the portal hypertension is diagnosed on the basis of presence of caput medusae. The definition of portal hypertension would be hepatic venous pressure gradient more than 5 millimeter of mercury. Investigation of choice for portal hypertension. Investigation of choice for portal hypertension would be answered as Doppler. And then subsequently we'll have to manage these patients accordingly. The complications that can occur in these patients can be in the form of GI bleed, or there can be development of complications like hepatorenal syndrome and hepatopulmonary syndrome. Quick answers here. Hepatorenal syndrome का treatment बोल देना. Yes, guys. Hepatorenal syndrome. Treatment that would be given would be two of them. Yes. One, we can use a drug which is going to act on the V1 receptors and is going to cause a vasoconstriction so that the renal perfusion will increase, that is terlipressin. And second, we can be using is salt-free albumin in a patient. Or another approach that we can be using is midodrine. The molecule we can be using is midodrine with octreotide to lower the portal hypertension component. Midodrine to cause increased renal perfusion. Octreotide to lower portal hypertension along with salt-free albumin. So treatment of hepatorenal syndrome has been asked. There are two approaches that can be used. One is terlipressin with albumin. Second is midodrine with octreotide with albumin. But it is always a salt-free albumin that would be used in this case. डोपामीन यार फिर तो वो शॉर्ट ड्यूरेशन हो जाएगा ना, मतलब कब तक देंगे उसको, तो आई थिंक इट्स लाइक मोर स्टैंडर्ड ड्रग्स दैट वुड बी यूज्ड इन दिस पेशेंट. टाइप 1 हेपेटोरेनल सिंड्रोम तो आजकल बोलते नहीं है ना. टाइप 1 हेपेटोरेनल सिंड्रोम इज कॉल्ड एज HRS AKI. सो उसमें भी ऑर्थोप्टिक लिवर ट्रांसप्लांटेशन आफ्टर द ट्रीटमेंट वुड बी फर्स्ट इज दिस ट्रीटमेंट ओनली, देन पेशेंट विल बी fit for surgery. Now if person is having renal failure, no surgeon will be ready to do a transplantation. So first we have to make him stable and then subsequently a surgery can be done in this patient. Hepatopulmonary is liver transplantation, doctor. hepatopulmonary syndrome will be having presence of platypnea. And for this, it is orthoptic liver transplantation and oxygen supplementation that would be done initially. हेपाटोपल्मोनरी सिंड्रोम में यार वो बेसिकली जो सिरोटिक लिवर होता है ना वो नाइट्रिक ऑक्साइड बनाता है, तो नाइट्रिक ऑक्साइड से ब्लड वेसल डायलेट कर जाती हैं एंड व्हेन पेशेंट विल सिट अप तो वो जो डायलेटेड ब्लड वेसल्स है वो लंग बेसिस को दबा देंगी, तो बैठेगा तो सांस लेने में दिक्कत होगी, जब लेटेगा तो ग्रेविटी का इफेक्ट यूनिफॉर्मली ऑल ओवर द लंग आ जाएगा, पर बैठेगा तो लोअर लंग बेसिस ज्यादा कॉम्प्रोमाइज होते हैं, सो दैट्स व्हाई लाइक द पेशेंट विल टेंड टू डिटेरिएट. सो लिवर ट्रांसप्लांटेशन इज द अल्टीमेट क्योर इन बोथ ऑफ देम, बट फर्स्ट इज मेडिकल स्टेबलाइजेशन या इन्वेस्टिगेशन चॉइस फॉर हेपाटोपल्मोनरी सिंड्रोम. बताओ चलो, investigation choice for hepatopulmonary syndrome. Yeah, there is a intrapulmonary shunting happening. What is the investigation choice that would be used for investigation choice for hepatopulmonary syndrome? Yes, guys, quickly. Bubble contrast echocardiography. It is bubble contrast echocardiography that can be used. Okay. Yes, very good, very good, very good. चलो अगला सवाल करते हैं, बहुत आसान सा है, क्रेस्ट सिंड्रोम पे है. मैंने बोल ही दिया क्रेस्ट सिंड्रोम बिकॉज आई जस्ट वांट यू टू क्विकली गो थ्रू द फर्स्ट ऑप्शंस है, बिकॉज देयर इज लाइक डिफिकल्टी इन swallowing of food, स्किन टाइटनिंग, रेनॉल्ड्स फिनोमेनन, telangiectasias, तो क्रेस्ट बन गया. उसने पूछा विच पैटर्न वुड बी प्रेजेंट हियर, सो दिस वुड बी सेंट्रोमियर पैटर्न. सो वो पैटर्न्स तो आप इवन रूमैट में मतलब पैथोलॉजी में भी पढ़ते हो, तो इट इज लाइक क्लिनिकल से ही सॉल्व हो जाता है ये वाला क्वेश्चन तो. एंड आई पुट अप अनदर क्वेश्चन फॉर यू गाइस. The following appearance of hands would be seen in which condition? The four options are in front of you. Which connective tissue disorder among the following will be having the following appearance of hands? Yes, this appearance is what is called as mechanics hands. And mechanics hands are usually going to be seen in anti-synthetase syndrome. That is option number B. The mnemonic for that is ASSET, A-S-S-E-T. Anti-synthetase antibodies against one of the antibodies that you see is anti-Jo1 antibody. Then mechanics hands can be present, synovitis, elevated liver enzyme, elevated muscle enzymes, that is CPK-MM, and then interstitial lung disease can be associated here. So ASSET is a mnemonic to remember regarding anti-synthetase syndrome that I've described here. Then antibodies for SLE, I don't think so that I need to describe before you. This is like very straightforward. So the last question that I put up for you guys is like this. Tell me the antibody for mixed connective tissue disorder. I mean, I don't think so. I need to talk antibodies for SLE. That are too primitive यार. उसका मैं क्या बोलूँगा? Anti-nuclear antibodies, entry level criteria, screening test, वो बहुत funny हो जाएगा. So I think that's too simple. Can you tell me the antibody for last question for today, guys? Which antibody is used for diagnosis of mixed connective tissue disorder? Yes. It is U1 RNP antibody, which will help in diagnosis of that would be helping in diagnosis of this condition. Yes, U1 RNP is ribonucleoprotein antibody. Okay, which antibody is most specific for diagnosis of dermatomyositis? Though the investigation choice for dermatomyositis is MRI guided muscle biopsy. Though the investigation choice is MRI guided muscle biopsy, which antibody is most specific for diagnosis of dermatomyositis? Has two alphabets only, like anti-Rho antibody and anti, like for dermatomyositis, the antibody most specific would be answered as anti-AMI2 antibody. Very good. I mean, these were like very straightforward questions that came up for dermatomyositis. It is anti-Me2, it is anti-Jo1 antibody in anti-synthetase syndrome, and anti-Rho antibody. Okay, I'll just write anti-Rho also. One, you read about anti-Rho antibody for S. Jogren. And second, you read anti-Rho antibody. You read anti-Rho antibody for photosensitivity that can be seen in patients with SLE. Along with this, the antibody can be transmitted to the fetus also. So the newborn baby of this lady can end up with development of a complete heart block. Mechanics hands seen in dermatomyositis may be seen, but is more a feature of anti-synthetase syndrome. So if he says mechanics hands, the first best answer should be given as anti-synthetase syndrome only. So guys, I think we are done for today. My last slide would once again emphasize you to go in for a mock test. That is my job as a teacher. to say that the more questions that you'll attempt, you will be in a better position to handle things. And thank you so much for your persistence and being able to hear me out. So we did 2 sessions, guys. That would be like long ones only. So I hope that I was trying to, though I spoke a little faster because I wanted to cover more, but my objective was to just make you sit through that duration so that you can focus on the core aspects. So thank you so much. God bless you. And I wish you the very best for the forthcoming exams. Next is that you are building yourself for the grand finale. As I can say, you are standing on the edge of greatness, and these days won't come back again. It's like याद आता है कि हाँ यार वो पढ़े थे, बहुत पढ़ा थे उस टाइम पे ना. I used to do sleepless nights and रात को 4 बजे तक पढ़ रहे थे, फिर सुबह जल्दी उठ के फिर कर रहे थे. तो I mean those days you will remember for subsequent on your life. So we'll be uploading Doctor so much very very soon. God bless you. Thank you so much for your persistence and hearing me out. Bye bye.